Good morning. I'm Dana Brown, LMU-DCOM class of 2015, and I will be your moderator today. Just a few housekeeping items to remember. Reminder that all virtual participants are set to mute. If you have a question, please type it into the Q&A box, and we will have the speaker address it at the end of session time, if time permits. If not, we will collect answers from the speaker and distribute the response to all registrants. All presentations will be able to view on demand online for 1 month following the conference. And attestation forms needed to claim CME credit may be completed by attendees today at the close of the conference. These forms will be distributed to in-person attendees and are available online for virtual attendees. PDFs of today's presentations are available at LMUlive.com, and disclosures for all speakers are available for inspection at the office of the LMU-DCOM Director of Alumni Services. So this morning I will introduce Tyler McCurry. Dr. Tyler McCurry is a native of East Tennessee. Born and raised in Cleveland, Tennessee, he attended the University of Tennessee, Knoxville, where he received his Bachelor of Science in Biochemistry, Cellular and Molecular Biology. Dr. McCurry then attended LMU-DCOM for medical school and completed a 1-year teaching fellowship in medical gross anatomy and OPP. After graduation, he completed his family medicine and OMM residency at ETSU in Johnson City, Tennessee. Dr. McCurry is board certified in family medicine and osteopathic manipulative medicine. He is the owner of Tennessee Osteopathic Center, a direct primary care clinic in his hometown of Cleveland. There he provides primary care, OMT, and acupuncture for his patients. Please help me welcome Dr. McCurry.
All right. Is this on? Yeah, there it is. Good morning. How's everyone doing on the last day of the conference? Doing well. All right. So today we're going to talk about different injuries that you can have in the office and how to treat those things with OMT. Disclosures. I don't have any disclosures. Nobody pays me. If you want to pay me, see me after. All right. So when it comes to OMT, how many of you feel like this? And I knew exactly what to do, but in a much more real sense, I had no idea what to do. Anyone else feel that way sometimes whenever you're thinking about OMT? So I understand in this room we're anywhere from maybe DOs who practice this quite a bit to DOs who haven't done it since med school, to MDs, to nurse practitioners and PAs. So my hope with this talk is that we give you some very practical treatments that you can do that are going to be very safe and applicable to a lot of your population. All right, what are our learning objectives? Ooh, that's a little slower than on my computer. Learn what the most common workplace injuries are. There we go. It's like the Doogie Howser computer. Be able to recognize and diagnose workplace injuries. Use OMT to treat the most common work-related illnesses and injuries, and know what the red flags are and when to refer somebody. All right, so congratulations. You just got hired on by Dunder Mifflin to be their occupational doctor. They want to put you in a clinic in their Scranton branch because for some reason that branch seems to have more injuries than everywhere else. So they needed someone with your expertise to be there and to help out their workers there. All right. So in order to prepare, you want to look up, okay, well, what are the most common injuries I'm going to see in a work site? So you go to the Bureau of Labor Statistics and you realize they have a lot of information and it's very difficult to sift through. So you start looking around to see if you can find something else that maybe consolidates that for you. Oh, thank goodness. All right. So we've got the National Safety Council here. They have what they call the injury facts. And what's really cool about this site is you can go through and you can do like the top 3, you could do the top 5, you could do 2020, you could do, 2018, however you want to do it. So if you look up the most recent one, which is from 2020, the top 3, they've shifted a little bit. So your first one here, right there, is exposure to harmful substances or environments. We can all thank COVID for that. That's what bumped that one up to number 1. Number 2 is going to be overexertion and bodily reaction. The most frequent part of the body that's hurt on that one, you guessed it, back pain. And then the number 3 is going to be your falls, slips, trips. Most frequent of those are sprains, strains, and tears. And then number 4 over there, you'll see it. You're going to have contact with objects and equipment, and then transportation incidents is number 5. All right, so you go to clinic your first day, and your very first patient walks in, and it's Oscar. Really nice guy, 33-year-old male, complaining of fatigue, sinus congestion, sore throat, and fever for 3 days. He's tried over-the-counter stuff, but it hadn't really helped. He's just not really getting any better. He has a mild shortness of breath when he's active, but doesn't have any chest pain, no confusion, no pale lips or blue lips or anything like that. Recently had dinner with a friend, the senator, who seemed to have an upper respiratory infection at the time. So he thinks he probably got something from him. But I'll say on exam, lungs are clear, vitals are stable. He doesn't have any concerning signs or symptoms. All right. You test him, what's he got? He's got COVID, wonderful COVID. And I'm not really going to go through all of this. I really want to stick to mostly the treatments so you have takeaways. The big thing I want to go over is the red flags for these different things. So with COVID, you can pull this from the CDC. The main symptoms you're going to watch for, and I'm sure everybody knows this at this point, trouble breathing, which would be more severe, persistent pain or pressure in the chest, worrying about, blood clots, pulmonary embolism, things like that. New confusion, altered mental status, difficulty waking or staying awake, pale gray or blue colored skin, lips, nails, depending on the skin tone. All right, so you diagnose him with COVID, you say go home and rest, but he's saying, hey, what can we do to maybe help me get back to work a little sooner or, get over this a little faster? Well, we've got some OMT for that. So I'll have my assistant come up here. So the purpose of OMT for respiratory symptoms is we want to try to relax the tissues, the musculature, the fascia, and we want to stimulate lymphatic flow. So I'm going to go ahead and demonstrate these techniques for you today. If you want to go ahead and have a seat. And if you'll face that way. All right. So what we're going to do, the first one here, I'll back out of the way. The first one here is going to be rib raising or paraspinal inhibition, whatever you want to call it. So what you're going to do, you're going to find the spine right down here, and then you're going to use, if the patient is sitting, you can use your thenar eminence, and you're going to go just lateral to the spine, make contact with the transverse process and the paraspinal muscles, and then you're going to push ventrally, so towards the front, and laterally. So you're kind of bowstringing that muscle. And so when I say bowstring, I mean think like a bow and arrow. You're going to pull back on that bow and you create that little curve. You're going to do that in the muscle group. So you're going to push and push laterally. So push ventrally and laterally. And you're going to do that all the way down. And usually I'm going to have my hand on the shoulder to keep them from feeling like they're going to be pushed off the table. But I got to hold the mic. So then you just work all the way down. And then you would do the other side. Now what you can do is you can either walk around and push this way on with the other hand, or you can just kind of do this way. And so the other way that you can treat, like how this picture has them, is they're laying down. So if they're laying down, your hands are going to look like this. I tend to like having them lay down. One of the reasons is when they're sitting up, they're a little more tense and contracted. If you have them lay down, they're nice and relaxed, and you can get a good stretch on that muscle. And then rather than just using one hand, you can use two, so you can cover a lot bigger area all at one time. So I'm going to have her go ahead and lay down, and we'll show you the others here. So the next thing you want to do after you've treated the thoracic region is you want to treat the cervical region. So the way that you're going to do that, you can either sit down and you can work that way, or you can stand up, and I'm going to show you both ways. So the first way that you're going to do that, and I'm going to explain it, and then I'm going to show it. Well, actually, I'll just have you hold that. There you go. I'll put you to work. So what you're going to do, you'll steady her head, and then you'll reach through here, and you're going to make contact with those muscles, and just pull straight up. And see how she gets a little bit of extension in her neck? You don't want to do so much that it torques the neck and hurts her. And you'll just work all the way up. Just like that. And the other way that you can do it is while you're sitting down and they're laying down nice and relaxed. I usually will start upper thoracics, and I'll kind of grab that trapezius as well, put some steady pressure there. And what you're going to do is you're just going to hold steady pressure and wait for those tissues to relax. And if they start snoring, you're okay. You're doing the right thing. So then here, what I can do, I like this way because I can treat both sides at one time. You're going to make contact with those muscles on either side of the spine and just pull. You're going to push ventrally and pull laterally. Very easy, very gentle treatment. You don't have to try to push them off the table. And then work up. And she volunteered because she knows she'd get a free treatment. So, all right, so the next thing you're going to do is a suboccipital release. So just below the occiput, that's where you're going to put your fingers. And just make contact with those muscles right there. Same thing, you're going to push ventrally and just hold steady pressure. If blood's squirting out of their eyes, you're pushing too hard. Back off. So you'll hold that steady pressure. And some people will do a rhythmic pulse, just kind of back and forth. Or you can just hold steady pressure. Either way is fine, whatever's comfortable for you and comfortable for the patient. There it goes. And so what you're feeling for is a softening of those tissues. So when I say softening, think of like warm butter. If you were to stick your finger into it, how it just kind of melts through. That's the softening and the melting that you're wanting to feel for. So this treatment here, you can either wait till you feel the tissue soften, or if you can't quite feel the tissue soften, that's okay. Just hold it for a minute, 2 minutes. All right. And so the next thing we're going to do is we're going to do a diaphragm doming. And what this is for, I'll grab that from you. So what we'll do with this is we're going to redome the diaphragm to help with lung compliance. So this is a respiratory illness. What we're trying to do is help them breathe a lot better. So you want to prevent any kind of atelectasis or anything from them splinting, which can lead to those secondary pneumonias that people get quite often with upper respiratory infections and especially COVID. This will also help with lymphatic flow as well. So I'll demonstrate that one for you. All right, so you're going to find the bottom of the ribs here, and there's a couple ways you can do it. You can either just use the pads of your fingers, and you'll just make contact, or you can use your thumbs. Either way is fine, whatever works for you. And so you're just going to make just steady pressure, contact with the diaphragm and those tissues, and then as she breathes in, you're going to gently resist. And as she breathes out, you're just going to gently follow it. And so one of the reasons I like to do this way with my thumbs is I can actually feel the lower ribs the whole time I'm doing this. I can feel them expand, and I can add a little bit of expansion to that as well. You do have to be careful because the ribs can be kind of tender. Okay. You just do that for a couple of breath cycles, maybe 3 to 5. Doesn't take very long at all. And then the last one that you're going to do is a lymphatic pump. Now that you've freed up all those fluid tracts and you want that fluid to flow, with a COVID patient, you may not want to do a lymphatic pump from the chest because then they might start coughing and breathing on you. Excuse me. So a lot of times you can do it from the feet, and I'll show you what that looks like. So essentially, and I'll just explain it, and then I'll put the mic down and show you. So you're going to dorsiflex the feet, and then you're going to pump with a rhythmic pace to help push that fluid through the body, and I'll show you what that looks like. So that's what that looks like. It's a real quick, easy treatment. The whole thing that I did, you could spend maybe 5 minutes on with a patient in clinic, and they feel quite a bit better. With a lymphatic pump, you can do kind of a rhythmic pulse, where you do it for a little bit, then you stop, do it for a little bit and stop, or you can just do it straight for like a minute. So whatever's comfortable for the patient, whatever you feel like doing. So, okay. If you want to hop up from there, you can have a seat over here. All right. So you treated Oscar. He's feeling pretty good. Told him to stay home for several days, let COVID pass. And then you get your next patient in clinic. All right. So your next patient is Daryl. Really nice guy, 34-year-old male, complaining of low back pain for the last 2 weeks. He manages the warehouse, and he's now more administrative with his promotion. So that means he's probably not quite as active as he used to be, maybe make him a little more prone to injury. He was helping fill orders while one of his workers were out, and he strained his back. Doesn't have any neurological symptoms, which is good. No radiation of symptoms, and the pain stays right across his low back at the belt line. So essentially, sounds more like, maybe an SI joint issue, lumbar strain, something like that. All right. So the big takeaway on this one is, what are the red flags for back pain? Because, we see back pain all the time in clinic. The red flags you want to look for are this one, and I like the mnemonic, tuna fish. Makes it easy to remember. If it's traumatic, if they have unexplained weight loss, so you're thinking maybe cancer, neurological symptoms, age is over 50, if they have fever, if they're an IV drug user, if they use steroids, or if they have a history of cancer, then you want to go through the workup here. Since he is under the age of 50, he doesn't have any systemic disease, no history of cancer, and no neurological deficit, it's okay to go ahead and do some conservative measures. And so we have some OMT for that. And so the muscles you're going to look for, you look at all these muscles here, the rector spinae, and you see all the big kind of tendinous attachments down into the tailbone. So if you're not quite sure what to do and you don't want to hurt somebody, I've got some treatments to show you that are going to be gentle, easy treatments that are going to help with this area and just help with like a myofascial release on that whole area. All right. If you'll have you lay face down, head right there. Okay. So the first thing we're going to do is we're going to soften and work on the lumbar soft tissue. And so the way to do that, there's different ways, but one of the ways that you can do is, see how he has his hand on the ASIS and he's kind of pulling up, and then at the same time you put a little counter pressure on the lumbar muscle to get a good stretch. So I'll show you what that looks like here. So it's just that quick. Then you would come around to the other side. So the same thing, the pressure is going to be ventral and lateral. You're trying to bowstring that muscle to get a good stretch on it. The next thing that you can do, you're going to work on the lumbosacral area. So this is a myofascial release. So myofascial is kind of a buzzword. You hear it all over the place with, myofascial guns, foam rollers, myofascial massage, things like that. Essentially what you're doing is you're engaging the muscles and the fascia, the soft tissues, to try to induce a relaxation. What's different about a myofascial release from maybe an articular type release is you're focusing more on those soft tissues and not so much on the joints themselves. So this one's going to be a pretty gentle, easy treatment that pretty much most people are going to tolerate. Now, with a myofascial release, there's a couple of different ways to do it. One is direct. So you're going to push the tissues in the direction of the restriction. Not everybody can tolerate that if you have a really tender site or if you have an acutely inflamed joint or muscle. They may not like the direct. Indirect, on the other hand, you're going to take the tissues where they want to go, which is going to be a lot easier on the patient because it doesn't stress the tissues out as much. Still get a very good release with that as well. So the way that you're going to do that, you're going to make contact with one hand on the lumbar spine, the other hand on the tailbone, the sacrum, and you're going to motion test each of those. So the way that you motion test is you're going to go superior, inferior, find out which one feels like it goes the furthest, and then you're going to hold that there. Then you're going to go side to side and feel which one it wants to go to the most, and you're going to hold that one. So you're stacking each of these restrictions. So up to the side, and then you're going to go clockwise, counterclockwise. And again, you hold that one there. Once you get those, you hold that steady pressure, and you'll feel those tissues start to soften and relax. So I'll show you what that looks like. And I'll say there's a couple of ways you can do your hands here. You can either do like this along the spine, or you can do to the side where you're trying to make more contact with the muscles on either side. It doesn't matter. Either way, whatever is more comfortable for you. All right, and so the treatment is just that quick. So, like I said, you make contact with the tissues, engage the tissues, move them where they want to go, hold it there until you feel all of it start to soften and relax, and you'll feel it kind of want to go back to a neutral position. At that point, you're done. You can retest and make sure they've got better motion there. So the last thing we're going to do is a sacral rock. This one is a great treatment for low back pain. It's going to help treat the SI joint restrictions because you're helping articulate the tailbone in that joint. This is also good for dysmenorrhea. It's good for pelvic congestion syndrome, different things like that. So what you're going to do is with one hand, you're going to make contact with the tailbone and the sacrum. The other hand is going to go over top. And then as the patient breathes in, you're going to follow that into extension. And as they breathe out, you're going to follow it into flexion. And so you're just getting a nice, gentle, easy articulation on the tailbone. Gets the tailbone moving a little better, helps open up the hips, and releases a lot of that back pain. So I'll show you what that looks like. Okay. So just as easy as that. So it's not too difficult. Okay? All right, you're good. And I'm zooming right along through these because I figure it's the last day you guys want to get out of here. All right. Oh, poor Kevin. They were having a chili cook-off, and he spilled his chili, and then he slipped in it. Poor guy. So he was able to walk on it immediately, which is good, but he did have a little bit of mild swelling, maybe a little bit of bruising. He's has a tender point at the anterior talofibular ligament, but negative anterior drawer test, so probably not torn, maybe just strained it a little bit. All right. So here is the anatomy of the ankle. So you can see this is going to be a rolled ankle injury. And so there's the anterior talofibular ligament. So it's going to connect here to the lateral malleolus, go into the talus there. So the tender point is going to be just anterior to that lateral malleolus. Well, what are your red flags that you're watching for? Everybody knows these, the Ottawa ankle rules, Ottawa foot rules. So first one you're going to look for, posterior edge of the lateral malleolus is tender. Posterior edge of the medial malleolus is tender. And then base of the fifth or at the navicular. So if you have any tenderness there or you have inability to bear weight both immediately and then they say in the emergency department or in your clinic, then you're going to want to go ahead and get an x-ray. So you might want to hold off on any OMT until you get that. All that looks okay, you're okay to go ahead and try some OMT in the office. All right, so what's your common strain pattern for a rolled ankle injury? Remember, this is a trauma. Traumatic patterns don't have any specific rules. They can do whatever they want to. So sometimes you get some oddball things that you find, but this is going to be a pretty common finding that you'll see. So the first one is the ankle prefers plantar flexion, and then you're going to have the anterior talofibular ligament tender point. Cuboid is everted and navicular is inverted. So if you think of how those two bones kind of come together, when you roll that ankle, they're going to push apart, just like that. And then your tibia is going to be posterior on your talus. So the way that looks is you have those two bones here, you have your tibia and your talus, and as you roll that ankle, relatively, the tibia is going to go posterior and the talus is going to go anterior. That's why you get that finding. And then with that, you're going to have the fibular head gets driven posteriorly. And that's mostly because at the ankle, as you roll the ankle, it's going to push that distal fibular, or distal fibula, it's going to push it anterior. And since that's like a cantilever bone, as you drive the distal portion anterior, the proximal portion goes posterior. And so that's why you'll see that finding. So how are we going to treat it? All right. So if you want to come back over this way. So the first one I have on here is going to help reset that talus on the tibia. So one thing you can do to diagnose this is just take your finger and kind of right at that ankle, put your finger right on that talus, and you're going to check, and actually she's got a little bit where she's restricted there, but she likes to plantar flex. So she's got a posterior tibia. So the way that you correct that is you're going to pull a little traction at this ankle joint to help separate those bones so they can kind of slide back into position where they need to be. If you don't feel comfortable doing the tug part of it, the high velocity maneuver, that's perfectly okay. The dirty secret with HVLA or high velocity is you don't always need the thrust. If you set it up correctly, most of the time it's going to go on its own. So if all you want to do is pull steady traction, that's perfectly fine too. It may go ahead and release on its own just doing that. So the way that you're going to want to do that is you're going to take the ankle, you're going to dorsiflex, and then I'll show you in just a second, and then you'll pull a little traction. Some people will do hands around both sides of the foot. I kind of like to grab the calcaneus too, because then I get a little bit of a treatment on that as well. So I'll show you what that looks like. And then if you notice, my pressure is going to be down to try to kind of push that talus more posterior. Okay, and then you just recheck. So she wants to move a little better. So we got that. The next part is just a mild fascial release of the foot and the ankle. Like I said before, with a myofascial release, we're not really worrying about the articulations. We're worrying more about just the overall structure and feel of the foot and trying to get that to soften and release. So one of the ways that you can do that, one hand around the calcaneus, the other hand on top of the foot, and you'll take it through those ranges of motion, see where it wants to go, and you hold it there till it softens and relaxes. So I'll show you what that looks like. And then when I get done, I usually will do a little articulation just to make sure all those joints are nice and loose and moving. So the next one you would do is counter strain for the ATFL. So like I said, tender point for that is going to be just anterior to the lateral malleolus, or the distal end of the lateral malleolus. And so with counter strain, if you're not familiar with that one, what we're doing is we're taking everything to the position of ease. So you push on that point and you tell the patient, is that tender? And if they say, yes, that's tender, you tell them, okay, that's a 10 out of 10. And then you find the position that's comfortable for them, that's a 3 or less. And so with this one, you're going to wrap that foot back around into dorsiflexion and more eversion to try to relax that ligament. And then you're going to hold it there for 90 seconds to give it a chance to relax and reset itself. So I'll show you what that looks like. Okay, we'll fast forward, say that was 90 seconds. And what you'll feel is you'll actually feel a softening at that area, but then also the patient will no longer be tender at that area. So it allows that ligament that's strained a chance to relax and reset itself. Because one thing with that ligament, what it's trying to do is actually restrict your plantar flexion. And so that's why that one is often injured whenever you roll your ankle, is because its job is already to try to restrict that, and it's kind of a weaker ligament anyways. So when you have that rolled injury, it's more likely to strain on you. All right. So the next one I'm going to show you is a balanced ligamentous tension for the posterior fibular head. Give me 1 second. And I'll try to keep my big head out of the way here. Will you hold that for me? Okay. So what you're going to do, you're going to hold the knee to about 90 degrees. And so this is also like it's kind of like the same principle as a myofascial release. What you're going to do with this one is you are focusing on the ligaments in the joint itself. So what you're going to do, so if that fibular head's posterior, and the way you would check for that, you can just very easily push back and forth to see if you feel, okay, it goes easy that way. doesn't want to go forward. The other thing you can do is you can plantar flex the foot, see if it drives that backward easily, and you can dorsiflex. And if it doesn't want to go anterior when you dorsiflex, you know it's kind of stuck posterior. So the way that you treat this is do your thumb just on top of the fibular head, and you'll have your other hand down at the ankle, and you're going to distract a little bit by pushing down. And then you can push it a little posterior as you plantar flex and invert the ankle and foot. And then you'll just hold that there till you feel it soften and relax. And you'll feel that bone kind of start to fight you, and it'll slide back to a neutral position. And then you'll come back and you'll test that range of motion again. And now it's moving, so you're good. The next thing that you can do with ankle injuries, you tend to see a lot of swelling either at the ankle or actually at the knee. One of the reasons that is with that posterior fibular head, all these lymphatics that are back here in the popliteal area get restricted and they can't flow as well as they need to. So I tend to like to finish off this treatment with a lymphatic massage of the leg. And I'm going to show you with her leg up so you can see it. Usually I have them laying down because then there's no restriction of the flow. But essentially what you're going to do is you're going to start more proximal and you're going to massage up. And then you'll work down just a little bit and go up. And you'll work that whole way just doing that to do that lymphatic massage. Just like that. And so I'll show you with her leg down. So then you can really put a lot more pressure and just massage through that area. And so you'll work down just a little bit more each time. Just like that. All right, let me find my clicker, and then we'll move on to the next one. There it is. If you just want to lay there. All right, so Angela's our final patient, 34-year-old accountant. Says that the chair at her office has been broken for a while now, so that's going to put her at risk for different wrist injuries. So if you think of someone who's typing on a computer, normally a good position is going to be right here in a neutral position for the wrist. If her chair's broken and kind of sitting down, she may be hyperextending that wrist a little bit, which is going to put a lot of strain there. So she's complaining of pain in the left wrist, a little bit of numbness. It's worse after working all day, so after she strained it a lot more. But doesn't have really any neurological symptoms, which is a good thing. So what are our red flags for carpal tunnel syndrome? So the first one is going to be if it's bilateral. Does anyone know why bilateral carpal tunnel is a bad deal? Think zebra right here. Cardiac amyloidosis. Bilateral carpal tunnel syndrome is a very, very early sign of cardiac amyloidosis and may precede it by as much as 2 or 3 years. So if you see someone who has bilateral symptoms, it may be worthwhile to keep an eye on them and make sure they don't progress to more cardiac-related symptoms. If symptoms are severe, they have a lot of neurological signs and symptoms, or they have muscle wasting, those are all things that you want to send them for further testing to go ahead and see what's going on. So, and as far as the pertinent anatomy, you have the transverse carpal ligament, which is the bad actor here, because that's what's pushing on that nerve. There's also the thumb muscles have been found in a lot of these patients to be hypertrophied, and they'll actually get into that carpal tunnel and start causing some of these symptoms as well. So that's why doing some work on the wrist and those muscles can help quite a bit. So I'll have Hope sit up for me. And then I'll have her hold the mic for me. There you go. So the first thing you're going to do is you're going to do an interosseous release. So there's a couple of ways. We'll do it right there. There you go. There's a couple of ways that you can do this. One is you're going to grab the radius and ulna between your thumb and finger. Hold steady pressure. Not too much, because this can be quite tender, but hold a steady pressure until you feel a relaxation between your hands. And when I say between your hands, I mean right through here. You'll feel all of that relax. The other thing you can do is a myofascial release. So you can engage the tissues here and here. And like I said, you're going to go superior, inferior. So she likes inferior. You're going to go medial, lateral, and she likes medial. And you'll go clockwise, counterclockwise, she likes that way. So same thing here. And then once you find that pattern, you hold it until you feel those tissues soften and relax. And so, I don't know if you can see my fingers are kind of sliding back to a neutral position. That's because the tissues are dragging it back that way. So then once you have that, that'll be good and relaxed there. So the next thing you're going to do is a stretch on that flexor retinaculum there at the wrist. So those tissues will get very tight, and that's what squeezes on that nerve. You can do this to help open that up and relax it. So what that's going to look like, you can do it in stages. You'll start, just take your thumbs and drag across there. You can do it 3 to 5 times. Then you're going to get even more of an extension by hooking around their 5th finger and their thumb. Extend a little bit. Do the same thing. And then you can extend even further by hooking around all the fingers and really get a good stretch on that area. So this is something you can also teach them to do themselves at home. They can lean up against a desk or something like that, put a little stretch on it, and do just a massage themselves. Works very well. I've taught a lot of patients how to do that, and they love it. So the other thing that you do is called the squeeze technique. What this is going to do is you're making contact, so right between your thenar and hyperthenar eminence, you're going to make contact with that same area on their hand, wrap around, and you're going to squeeze those carpal bones, and then you're going to have them squeeze a fist. That's going to kind of make it almost a muscle energy technique, and you're going to reset those carpal bones and get everything moving again. And we might get hers to pop, because hers usually does. Although I just did this last night, so maybe not. So like I said, palm to her palm, wrap around the thumb, and then directly on the other side, you'll squeeze it around and then tell her make a fist, and then relax. See, I don't know if you heard it pop or not, but it did. Then what you're going to do with this, you're going to add a little bit of articulation to it. So I do a figure of 8. Do that a couple of times, and then I go back the other way. So that just helps loosen up all of those carpal bones and gets that area moving again. This is actually one of my most requested treatments in my office. So it seems pretty easy, but people love it. So, okay, you're good. Thank you. All right. So that's pretty much it. As you're finishing clinic, you get called out to the parking lot because this place is crazy. Oh, poor Meredith. She got hit by a car. What OMT you're going to do for this? You're not going to do OMT for this. The red flag is she got hit by a car. So car plus pedestrian equals an ambulance. So send them on to the hospital. All right. So what are some texts that I recommend that people use? I use these 3 almost on a daily basis. The first one we used in med school, Atlas of Osteopathic Techniques. This one's a very good book. Journal of the American Osteopathic Association. You can actually get on their website and search through all their journals and find, if you're looking for carpal tunnel or whatever, You can find any journal articles they have on that. And then I use this one as well. This one's a good one too. All right. Any questions?
How long do COVID patients experience relief after a treatment, and do you do multiple treatments throughout their course?
Everyone's different. Usually one treatment will be enough to get them through the whole thing. If they're older and they have a lot of comorbidities, they may need 1 or 2 more treatments. But most of the time, it's just been one treatment and they're done.
Any other questions for Dr. McCurry?
He's making you run today.
Yeah.
Yeah, I'm just curious, do you offer OMT as part of your monthly DPC fee, or is that an additional charge?
So the way that we do it, we didn't want to feel like we were nickel and diming people. So we offer 6 visits per year per patient as part of their membership. If they go beyond that, it's $30 a treatment. So we made it very, very reasonable, to the point that I've had a couple of patients that are like, just schedule me every 2 weeks. I don't care. I'll pay it. But honestly, OMT has been the biggest driver to my practice of getting people in. I don't have as many, I have quite a few DPC patients, but I still have a lot of patients that come in for just one-off visits for OMT. Anybody else? And I'll tell you, I had links in these, in the PowerPoint. Those links are to different videos that you can watch. That'll show you all these techniques that I did. So if you feel like you need a refresher, you can follow up with those. All right. Nobody else? Thanks.
Okay, we'll take about a 15-minute break and start back at 8 o'clock.
All right, we'll get restarted here. Dr. Clay Gwynn is an osteopathic physician who is triple board certified in both allopathic and osteopathic physical medicine and rehabilitation, as well as sports medicine. He completed his residency at the University of Kentucky and his sports medicine fellowship at Nova Southeastern University. He currently works at Sports Medicine south of Gwinnett in Lawrenceville, Georgia, and is the team physician for 3 local high schools. Additionally, Dr. Gwynn is an adjunct clinical professor at GAPCOM, Georgia PCOM, and part of the core faculty of the Sports Medicine Fellowship at Northside Hospital. In his free time, he enjoys spending time with his wife and their 2 golden doodles. Please help me welcome Dr. Gwynn.
You can use this. Is it on already? All right. Thank you for having me. So, as it says, we're going to talk about some nerve-mediated pain treatments that I use. I work in a relatively large 4-office orthopedic sports med practice, and I do a lot of the sort of interventional pain type procedures for my partner. So, quick disclosure, I'm a paid physician consultant and key opinion leader for Pacira Biosciences, which one of the things I'll be talking about today is the iovera device, and that's the company that owns it. So quick objectives, basically going to use case studies, about 4 of them, to discuss types of patients that may come into your office that potentially could benefit from some of these minimally invasive nerve-mediated procedures. So common things, I'm sure we all see, certainly I'm sure the PCPs see very commonly too, low back pain, knee pain, shoulder pain, and then kind of quote-unquote nerve pain that people come in with, sciatica being one of them, but nerve impingement syndromes, myofascial pain can be something really common that I see as a PM&R doc, and I'm sure as PCPs you guys see a lot of that as well. Neuropathic pain from things like diabetic polyneuropathy, post-herpetic neuralgia, things like that, and then CRPS too. So all really common things that some of these things that I'm going to be talking to you about could potentially, patients could benefit from. So common kind of traditional treatments for orthopedic type pain and injuries and the neuropathic pain, certainly all these can be successful, but this talk is kind of more focused on people who have failed these things and options that could potentially help them if these more traditional things don't work. So physical therapy and modalities like shockwave therapy, ultrasound therapy, laser therapy, bracing, especially for like carpal tunnel, cubital tunnel type issues. Over-the-counter creams for the neuropathic pain patients, so capsaicin, lidocaine, things of those nature. Oral medicines, I forgot to put it on there, but certainly Tylenol, ibuprofen for the orthopedic, but then for the neuropathic pain, the gabapentinoids, Lyrica, things like that, of course, are things that we're using for people with the neuropathic side of pain. And then there's injection therapy, especially on the orthopedic side, corticosteroid injection being the most common things that's been done for years. Of course, we still do it. We're doing more and more now PRP or platelet-rich plasma stem cell type injections as well. And then, of course, surgical intervention for especially the neuropathic type stuff, if it's severe or has muscle wasting, atrophy, and other neurologic symptoms, or joint replacements, things like that for our knee pains, hip pain, stuff like that. So again, this talk's kind of talking about, so what do we do in those patients that either refuse surgery, are not a good surgical candidate because of other health reasons? So we still need to be able to offer these patients options. And I think at this point, luckily we're at a point from an opioid perspective, we're really not trying to give patients opioids, especially not long term. And I think that interventional therapy, some of these options that we're going to talk about here in a minute, are really what, in my opinion, I personally push patients towards, and what I think PCPs and just in general, we should push patients to get more procedures and manage their pain from that perspective, change their lifestyle, things like that, as opposed to just giving them meds to deal with said pain. So the 4 different types of treatments that we're going to talk about today, number 1, nerve hydrodissection, number 2, radiofrequency ablation, number 3, cryoneurolysis, and then number 4, peripheral nerve stimulation. So first, we'll go into this first case here. So got a 45-year-old male, presents with pain that happened after a weekend working on his deck at his house. Has some pain over the medial elbow, worse with pronation, supination, radiation of pain into the digits 1 through 3. He tried rest for a couple weeks. He tried ice, heat, NSAIDs, over-the-counter sleeves and creams didn't really work very much. So he came in. I do electrodiagnostics, but also do a lot of diagnostic ultrasound as well. And here's his workup was, so we did an EMG. It showed some mild impingement of the median nerve, not at the carpal tunnel though, at the pronator teres. So that's the second most common place that the median nerve gets entrapped in between the two heads of the pronator teres. So it was mild though. Patient didn't have any atrophy or anything like that. And it didn't show anything as far as cervical radic or ulnar neuropathy, no carpal tunnel. And again, that's kind of an example of the ultrasound there. And so what is his treatment option? So certainly we can do physical therapy. You can try steroid dose pack. You can do those things. But one of the things that I've found pretty effective in my patient population is a nerve hydrodissection. So what that is basically using an ultrasound. We see the nerve. We can see, I've already done the electrodiagnostics, so I kind of know where the nerve's being impinged or thereabouts. And then on the ultrasound, we can see, at least in some cases, we can see some swelling of the nerve. We can kind of localize that area that it looks like there's maybe some fascial adhesions, where the pronator teres is kind of impinging it. And then we can stick the needle both above, on the side, and below of the nerve and push some lidocaine. I usually put steroid in there too, and try to help release from those adhesions, and then put some of the steroid around the nerve to try to cool off the inflammation, which quite drastically can help people, especially with mild impingement, really quickly. They can even leave feeling a lot better. So like I said, like it says here, it does work well too when coupling it with like, for example, if you do an ulnar nerve, coupling it with nerve glides, doing kind of physical therapy stuff for whichever nerve you're focused on. And so what I've found is that it's really good for mild nerve symptoms. And then the other way that I use it in more moderate and severe cases, if you have someone that has what's called a double crush phenomenon. So we see a lot of people a lot of times that have symptoms like on the little finger, and they have like a T1 or C8 radiculopathy, but they also have an ulnar neuropathy too, like cubital tunnel syndrome. So what's actually currently causing their symptoms, or is it both things causing their symptoms? And so I get referrals from my colleagues sometimes to do like an ultrasound guided ulnar nerve block, and if it relieves all their symptoms, then we would typically, my hand surgeon would go ahead and move the ulnar nerve, do that surgery, see how the patient does, and then if he's not fully better, then would consider getting the patient over for like epidurals or to the spine surgeon and possibly doing that, or vice versa as well. If it looks, they don't get a lot of relief with the ulnar nerve block, then maybe it is more of the neck causing the current issue, so maybe we need to do an epidural first, or get them potentially over to spine surgery to do a fusion, or release the nerve from the neck perspective. So common conditions that I treat with this, carpal tunnel syndrome is probably the most common one, where we do someone that has mild to moderate carpal tunnel syndrome, do the injection, then get them in to physical therapy using the night braces for 6 to 8 weeks, and then if that doesn't work, then surgery. Pronator teres syndrome, as I just highlighted, that's another one that I do pretty commonly. And then the other ones are perineal neuropathy, especially at the knee, because that's a really common one. I have a lot of partners that do total knees, so really common to get perineal neuropathy, or at least perineal nerve stretch injury and things like that after surgery. Can be severe, but often, more times than not, it's more of a neuropraxia, kind of mild nerve injury that's going to heal itself. But there are patients sometimes that have pretty significant symptoms, so as long as I get the blessing of my surgeon to put some steroid around a total joint patient, and they usually don't mind, because where I'm injecting is kind of behind the knee, so it's usually not a major risk, and it's under ultrasound. I'm not going to be putting it in their joint that they just put in or anything. So, and then myalgia paresthetica is another really common one that the nerve hydrodissection can really help with, because I see pretty regularly a patient that comes in for like a lumbar radic evaluation, but they actually just have some myalgia paresthetica, and they'll tell you they wear a tight belt, or they lost some weight, or something like that. And so that's another good option to help, again, do a procedure that helps someone feel better when they're leaving your office. And usually, I think that's kind of what a lot of people expect when they come to the orthopedic office, is they want to leave feeling better. So take-home points for that. So minor nerve impingement, they usually don't need surgery, but they can, at least from what the patients will tell you, cause pretty significant symptoms. So having an option like this to help with the symptoms, to hydrodissect the nerve, is a good option. Certainly not an option for a person that comes in and has multiple nerve impingement. If they have like a mononeuritis multiplex, which can be coupled with like a rheumatologic disease. So it's definitely better when you have more focal, carpal tunnel syndrome, ulnar nerve at the elbow, perineal nerve at the knee. And in my personal opinion, I think definitely if you're injecting around nerves, you should have ultrasound guidance and know how to use the ultrasound and see the nerve and know that you're around the right nerve. And then again, the last thing, it can be a definitive treatment, especially in those minor nerve impingements, or it can be also, help them out for a little bit or be more diagnostic in the nature of if you have an EMG, it's positive, but we're not totally sure that that's exactly what's causing their symptoms. Like I said, in the double crush type of an option there, it can help, again, us as the team working with our surgeons. Is this the surgery they need first, or where exactly is this, what needs to be done first, basically. So, all right, case 2. So 59-year-old male has chronic right knee pain. So he's relatively unhealthy, chronic kidney disease. He's on hemodialysis, has diabetes mellitus that's not too well controlled. Pain's worse with ambulation, better with rest, has an effusion, joint line tenderness, and he's done a lot of the common other treatments, no major improvement with rest, PT, ice, heat, NSAIDs, OTC, sleep creams. I think he probably forgot to put it on there, but tried a steroid injection too. So what are we going to do for this patient? So there's his radiographs. He's got really severe loss of joint space there, comparing that to normal. And so he's got severe medial OA, moderate severe lateral joint, and patellofemoral OA. So this is a patient that often, for me, I would recommend a radiofrequency ablation procedure. So, and I get a lot of referrals for that because that's usually a patient that most surgeons are not going to want to operate on. So unfortunately, these patients will get kind of stuck in a situation of we want to deal with pain, or we can't deal with this pain. We want to get out and do stuff with our grandkids. We want to walk our dog. And so this is something that can help them do that. So what is radiofrequency ablation? So it's basically a heated needle. There's different types of radiofrequency ablation in terms of how hot it is. The one I use is 60 degrees Celsius. More traditional radiofrequency is at 80 degrees Celsius. But it can be done under either fluoroscopic or ultrasound guidance, where we actually go in and go after the genicular nerves which innervate the joints, which of course, and since it is an ablation, our goal is to cause neurotomesis or complete, irreversible nerve damage. So we say irreversible nerve damage, but the body actually has a really good ability to try to heal itself. So the nerves still do try to grow back. They grow back at 1 millimeter a day. And so the averages of the studies, at least with the company for the RFA machine that I use, is 6 months to 2 years of relief. I can tell you I've definitely seen people with slightly less than 6 months. I've definitely seen people with 3-4 years as well. So, but certainly when we're talking to patients, we're going to tell them what the studies show. And then, everyone hopes to have longer than what we tell them. But because we're doing a nerve-mediated procedure, it takes 3 to 4 weeks for full effect. And that's because we have to let the process of Wallerian degeneration occur. And so we have to allow that 3 to 4 weeks for that nerve to die back. And that's why we have to educate our patients they don't technically wake up from the procedure. We usually do it under MAC anesthesia, feeling like perfect. They actually kind of hurt a little more for a little bit because of the soreness that ensues upon that, doing the procedure. So who can benefit from these procedures? So people who have failed other conservative measures. So they've failed kind of all the things I just mentioned with therapy, weight loss, creams, meds, steroid injections, visco, things like that. All those are really good options, or this is a good option for a potential patient for an RFA. As highlighted in the case study here, someone who's medically unable to get surgery. So we definitely see those people with the kidney disease, liver disease, things like that. It's a really good option of a procedure that we can help their pain. And I think it's important to highlight too, our goal is always to, of course, have no pain, but we consider this procedure successful with 50 to 100% pain relief. So, I can tell you from doing a decent amount of these, if you can make someone who's living in 8, 9, 10 out of pain, if you can make them a 4 or 5, they're going to love you for the rest of their lives. So they can walk their dogs, they can manage their pain a lot better. So, again, always going for 100%, but, if you can take someone's pain down by 50%, that's a very significant thing. And then again, there are actually quite a lot of people out there that don't want to have surgery. They're great candidates for surgery, but they just personally don't want to have surgery. So this is, again, another option for those people who have failed steroids, have failed visco, maybe aren't a great candidate, or have failed, even the PRPs and stem cell type stuff. So a couple side effects. I don't see these very often, but it is possible to get a partial nerve treatment. So you can get what's called a dysesthesia. So the nerve goes into overload because you didn't fully treat the nerve. The good news is usually you can treat it with some oral steroids or just go back in and retreat the patient, and the dysesthesias will go away. Or sometimes if you give them some gabapentin for a little bit, that'll go away as well. And then, of course, the side effect is damage to the nerves, but that's actually what we're doing, is damaging the nerves. So that's really the goal here. And because it's a heated type technology, we can burn the skin. I've never had that happen, knock on wood, but it is possible because it's a technology where we're heating up the end of the needle. So here's an example of the actual machine I use. CoolLeaf, funny enough, is the company that I use. The reason it's called CoolLeaf is because it's at 60 degrees Celsius, whereas the traditional RF was at 80 degrees Celsius. But what they found was that using a little bit cooler temperature, of course, 60 degrees Celsius isn't cool. It's relatively pretty hot. But we're able to get a larger burn radius. So this machine here actually can get up to 5 millimeter burn radius, whereas some of the more traditional, and it's a circumferential burn, whereas old school RFA isn't a circumferential burn, and it's usually a couple millimeters. And so as this case highlights, knee osteoarthritis, definitely a good patient to treat with. Probably most commonly what I do with it and what most people do with it is spinal disease. So lumbar, facet arthropathy and SI joint pain all can be really, we see a lot of patients that I've treated with this that really have some really good results with this. And then don't do this very often, but I've treated about 3 or 4 people for shoulder osteoarthritis, get a couple referrals a year from an orthopedic surgeon, someone who's too unhealthy to undergo surgery or just really wants to postpone their shoulder joint replacement. And the ones that I've done got about, I think it was like 10 to 12 months of relief after the RFA. So pretty good, for people to be able to get back and do what they want to do. And again, this is a minimally invasive treatment. So, it's just poke holes. There's about 3 poke holes that we do. So quick recovery time. Still have to allow the 3 to 4 weeks of Wallerian degeneration, but still quite a quick recovery, especially when compared to shoulder replacement. So take-home points: RFA, or radiofrequency ablation, is a safe, minimally invasive, opioid-free treatment to reduce pain. It's definitely good options for those patients that are non-surgical candidates, but also an option for people who just don't want to have surgery. Or there are also, and I'm sure you guys have seen it in your clinics too, it's another good option for people who still have pain post-arthroplasty. So there's definitely, since I'm not an orthopedic surgeon, I don't know the exact numbers, but there's definitely a subset of patients that get total hips, total knees, and they don't get better. They still have pain. So this is another common referral I get, and something that you guys as PCPs can think to potentially recommend to patients, that still have pain after their joint arthroplasty. Because of course, the reason for the arthroplasty is to help their pain and to make it go away. After doing quite a lot of these, I can tell you it's tolerated well by patients. We do it, again, most commonly under MAC, but I have done it only under local anesthesia as well. People tolerate it well. I think that question, and patients ask me about it all the time, but I think that really just comes down to the patient. There's some patients that can tolerate more things than others. So you just have to kind of know your patients and get to talking with them. And a lot of them will just tell you, I'm a baby, I need sedation. And if you should probably sedate the patient that tells you that. So, and then as the last thing here, can reduce pain 50 to 100% for 6 months to 2 years. And the last thing to say about this is before I ever do one of these, we always do a nerve block. So we block the nerves, basically same procedure that I would do with the RFA needle, except we just put lidocaine around the nerves. And if the patient gets adequate relief, then we'll proceed with doing the RFA, because patients get scared when they hear hot ablating things. But then you do a block, they see that they got like 80% pain relief, and they kind of like that. And so that's a way we can sort of talk with the patient and be like, if you like these results, let's do it. If you don't, let's not do it. So, and I will tell you that more often than not, they pretty much like the results of the block, and then they also like the results of the RFA. So it's a good option we use pretty commonly. So case number 3, so pretty similar patient, except chronic knee OA, had it for a long time. This patient's healthier. He has hypertension, but definitely kidneys and all that stuff and no diabetes, doing well. Same sort of history, joint line tenderness, effusion, worse with ambulation, better with rest, classic osteoarthritic type history. Again, no major improvements with all the common things. He'd also have steroids, visco. He had severe OA. Studies show for PRP, it usually doesn't work as well in severe OA, so the patient didn't want to even consider that. So this patient was actually planned for a TKA. Same kind of, radiograph that he had. So this is to highlight what's called cryoneurolysis. So what is cryoneurolysis? This is probably one of the most common procedures I do nowadays. So cryoneurolysis is actually an old procedure that's kind of being used a little more now. And at least in this sense, first let's talk about what it is. So it's application of a cooled needle tip. So we're not actually injecting anything into the patient. We have a specialized device, which I'll show you in a minute, that has a nitrous oxide capsule that we put in there, and then it sends down cold to the tip of the needle, and it makes an ice ball. And then under ultrasound guidance, we put the ice ball on the nerve. We treat it for 106 seconds, and then it freezes the nerve, causes a type 2 nerve injury, so it's a reversible nerve injury or a neuropraxia. So after we do it, and the most favorite patients that we're doing it in, at least currently, one is as a pre-total knee. So it's a long-lasting nerve block. So I started this about a year and a half ago, and my first patient was actually my orthopedic 65-year-old partner who had bilateral total knees. And he told me, if it works, we're going to do it in all my patients. If it doesn't, we're never going to do it again. So it worked, and we do it in the majority of our patients now. But what it does is it causes the neuropraxia. So we are quote unquote damaging the nerves, but it's a reversible damage. So we do it about 3 to 4 weeks before they have the surgery, and then they have another 2 to 3 months after their surgery that they have pain relief. We started a study at our office, and we decreased our opioid amount, because my surgeon's an old school surgeon, so he gave a lot of opioids. We decreased our opioids by 70% after implementing this procedure, just because of the pain relief that it provides. And actually, some of the anesthesia guys that work at my hospital came to me and said, we think we're going to stop doing some of the blocks that we do, because their knee goes completely numb, because we block all the superficial nerves that go to the knee, and we actually can do the genicular nerves as well. So it's so far been a really good addition to help with pain as a pre-TK option. And again, for me, it's more about decreasing the opioids. That's what it's really all about, is the decreased opioids. So again, same as the RFA, we can have a dysesthesia. So that's again from a partial nerve treatment. But again, it's not that big of a deal. We just retreat the nerve and it goes away. Or sometimes it goes away on its own if you just give them some steroids or gabapentinoids. Because it's a cold technology, there is a risk of skin freeze burns. And so we just educate people that what to do if they do. It's just kind of a grade 1 burn if they ever get one. So it goes away in a week or 2 on its own with some minimal treatment. And then, of course, anytime you stick people with needles, bleeding, infection, those are also rules or possibilities of things that happen with that. So common conditions we treat with this. So certainly by far, knee osteoarthritis as just a treatment on its own, or pre-total knee is definitely the most common things that we do. But since I started out only doing knees, but now we've kind of branched out. I did one patient that had rotator cuff, a complete supraspinatus tear that my surgeon wanted to do surgery on, had him scheduled for surgery, but then anesthesia said no because of his heart. And so I actually treated his suprascapular nerve, and he had 100% pain relief, and that was like 6 months ago, and he still hasn't came back. So technically the technology shouldn't last that long, but assumingly he either got surgery or last time I saw him, he got at least 3 months of relief though, so he was pretty happy about that. And then the most exciting one that I'm excited about is I've treated 3 patients so far and to help with the pain of spasticity. And so I'm sure you guys know what spasticity is, but it's that recovery stage after stroke where patients have unrelenting muscle spasms essentially because of the nerve damage they have. And like I said, treated 3 patients so far with that and completely relieved their pain. They're doing better than my Botox patients. And so it's a really exciting option, I think, that I'm now offering on a regular basis. And I think we're going to see more and more of that in the coming years too. So take-home points, cryoneurolysis is a safe, minimally invasive, opioid-free treatment to help reduce pain. Definitely good for pre-TKAs, and we just recently implemented one for total hips as well, so I do a total hip block as well now. And then again, can help with the pain of spasticity, can also help, I've treated a couple CRPS patients as well, and they got about 60% relief in pain too, so that's another potential avenue that this can be used. And then again, we have to tell people what the physiology says and what the studies show. Can help reduce pain for 3 months, and it's through neuropraxic damage using cold technology. But after seeing some of these patients, some people are getting longer than 3 months. So, but again, we tell patients 3 months because that's what we can reliably say. So then the last case, similar type patient, OA, hypertension, classic OA story, failed all the things. And so another option that we can implement now is called PNS, so peripheral nerve stimulation. So it's something that I guess you could say is a competing thing but for cryoneurolysis and for radiofrequency ablation. But as with all treatments, I mean, it has its benefits just as the other ones have its benefits. So what is it? It's the use of an implanted peripheral device that we keep in for 60 days, and it at a low level constantly stimulates whatever nerve that we're putting it around. Again, since we're doing these nerve procedures, it is and should be guided either by fluoro or ultrasound. I usually prefer ultrasound because you can actually see the nerves, but there are fluoro techniques as well. Again, the goal is pain relief, and the kind of cool thing about this is it actually doesn't cause any nerve damage. It just stimulates the nerve. So these are kind of similar patient populations. Again, all the RFA, cryo, and peripheral nerve stim patients, they're all kind of the similar same patients. It's just, some patients don't like the thought of burning something. Some people don't like the thought of cold. And so, and again, this is the one that doesn't actually cause damage. It just stimulates the nerve. So again, people who can benefit, they fail conservative measures. They're medically unable to get surgery is a good option for them. If you have a personal preference to avoid surgery, also an option. And again, very minimal side effects, pain, bleeding, infection, most side effects of anything time you stick a needle in somebody. And so this one is actually our favorite to use for CRPS and post-amputation pain. Some decent evidence for that. It can also be used for chronic migraine, put in around the occipital nerve in the back. Chronic neuropathic pain, post-surgical pain, also an option, and then also can be helpful for chronic facet arthropathy or radiculopathy. So essentially you just need to know which nerve is causing the pain. So electrodiagnostics or good clinical exam can be helpful for that. And again, this is an option that helps some of these people that have failed back syndrome, that have had surgeries, or they're not candidates for back surgeries or knee surgeries and things like that. So it's another good option that we have. And as you see pictured here, that's an example there on the left of what it looks like. There's 2 little leads that you put in, and essentially you hook them up to that little machine on the right of that person's back, and it's kind of like I'm sure you guys have heard of spinal cord stimulation. It's basically the same thing, except it's just you're stimulating a peripheral nerve and not a nerve in the spinal cord itself. So it's pretty easy to do. Like I said, pretty minimal risk. Then they just keep it in for 60 days and really not seeing a lot of infections with it. And so, it's just another good option to have in our toolbox for that subset of patients that can't or won't get surgery and have failed all the other traditional things. So some take-home points about that. Again, PNS, it's a safe opioid-free pain option. Recommend personally ultrasound-guided placement. You keep it in for 60 days, but studies can show up to a year of relief in any of those areas that is placed. Minimal side effects, and again, it's definitely a good option for post-operative pain or chronic pain patients, especially like in the back. And so final thoughts, so hydrodissection, definitely a good option to consider for mild nerve irritation impingement, especially, or even in those, I've done it in patients that have EMG negative, but they just have kind of like a neuritis of the ulnar nerve or something like that. I see that a lot in baseball pitchers. Cryoneurolysis is a good treatment, especially for a pre-TKA, but also for neuropathic pain, pain of spasticity, and we're finding useful now for other joints like the ankle, the hip, the shoulder. Radiofrequency, again, similar patient population, but do that a ton for SI joint pain and facet arthropathy, but also can be done in the peripheral joints as well. And then peripheral nerve stim, again, same patient population, probably the best one for CRPS and chronic radic, though, if it's not responsive to surgery or epidurals and that sort of nature there. So there's references, and then any questions?
Great talk. I'll admit I'm only aware of one of those four modalities, so very informative. Question for you: with these minimally invasive techniques that you're using, looks like you're getting great results. Is there really any role for me as a family medicine doctor to do like a knee steroid injection anymore, or should I just send them to you for one of these options?
So it's kind of a complicated question, I guess, but I think for my perspective and what most of my orthopedic surgeons that I work with think, if you already have osteoarthritic damage, it's not going to hurt them to do a steroid injection, especially one or two. These ones that I'm talking about, I mean, I'm sure you guys have all seen, there's these patients, they come in, they want their steroid every 3 months, and then before you know it, they're asking for it every 2 weeks or every month or something like that. I mean, that's, I don't think, appropriate. I think, if you do a steroid injection sometimes and it lasts for a year, that's great. I mean, once a year when you're 65, if that helps you, then I think that's fine. But I think that you shouldn't get steroids all the time, and then I think you got to add in the thought of the diabetes effect on that. And that's this is just a random thing to add in, but I don't know if you've heard of the steroid Zilretta, but it's a long-acting slow release steroid. And we use more of that in our clinic, especially for our diabetics, because there's studies showing that they don't get the glycemic increase that the traditional steroids are getting. So it's called Zilretta. So it slow releases. It has little microspheric beads that when you put it in the joint, it slowly releases over like months instead of just, releasing really quick like that. But, I think there's definitely a role for PCPs to do steroid injections for sure. And certainly one or two, I don't think hurts anybody. And I mean, honestly, from a sports med perspective, we get these high school, college, and even professional athletes that are young, but we look at the whole picture of what's going on with the patient, and, we inject 18-year-olds with steroids sometimes, because it's a quick option to get them in so they can feel better and get their scholarship, and then my surgeon fixes the meniscus at the end of the season. I don't ever really recommend to do the steroid in young people, but because I'm more of a proponent for the PRP injection, so I try to push them to that. But unfortunately, that costs money, and not everyone has $600 to pay for PRP. So, but I definitely think there's a role for primary care doctors to do steroids.
Are any of these approved for children or at least adolescents or teenagers with chronic pain?
Yes. So the main one, at least that I do, because I see predominantly probably like, I'd say 14, 15 plus is what I see. And so the cryoneurolysis is for sure. So I've been, like I said, doing it for a year or so, and they just got it at CHOA in Atlanta, and they're starting to do it on CP kids as well for that. So, and I'm like one of their main referral sources now, where I take their kids over after they leave CHOA, because they're like inundated with patients with CP and things like that. So for the pain of spasticity, definitely something I've used before, and they are starting to use at CHOA, I know, because I know some of the docs there.
Kind of a piggyback off of the previous question, is there some low-hanging fruit, a pattern that you see that you go, oh boy, I wish the primary care had done this before they'd come to me? Or even if it's something simple, you mentioned dust packer, is there a trend or anything that you've seen that's like, I wish I was seeing more out of this before they come in for these really common complaints?
Yeah. I mean, I think it's definitely, I like it, and I think this would speak towards like orthopedic surgeons that I work with too. We love it when people come in already worked up. So if you get an MRI, we love it, because we don't have to waste a visit and get an MRI. So if they come in with an MRI, or even, if it's a knee or something, I don't mind if, someone's done a steroid injection or anything like that either. So I think, ordering the MRI is great. I think part of it's like insurance makes it hard as well sometimes, right? Because, there's so many rules that have to be followed, and you guys have a million other rules that you have to follow with different guidelines and stuff. And so at least from the PCPs that I work with really commonly, they tell me that they find it easier to just send the patient to us, and then we do all that stuff, because insurance just makes it so hard. And unfortunately, I know all the rules of how to get a low back MRI, knee MRI, shoulder MRI, what insurance is going to require and that kind of thing. So, at least for like low back, for example, one of the most common things is 6 weeks of therapy. So for your question, if you just go ahead and order therapy, if you kind of rule out, oh, I don't think they have back cancer, I don't think they have, maybe they have a radic, but they don't have any severe weakness or something like that. If you go ahead and get them into therapy and then even just refer us on to us, I think that helps us, because more often than not, we see a patient and, they expect that we're going to order an MRI, but we can't, because Blue Cross says you have to have 6 weeks of conservative care before you can get your MRI and things like that. And I think people come to the specialist thinking, I want to get things done and I want to get it done fast, but insurance doesn't really care about that. So I think ordering a lot of therapy is pretty helpful from my perspective for us. And like I said, I mean, but you also got to find that line of, if you're like, man, I think they have like a stress fracture, or I think they have, something serious, then you do have to, push them to the specialist and get that MRI, and not always get jaded by, oh, well, insurance is going to require 6 weeks, because, if they have a certain thing, just because insurance is going to make it difficult, you got to fight for your patient to get what's right for them. Hopefully that was helpful answer.
I guess a couple questions. For, I guess, an example from my family, like my grandmom is 87 years old, a little heavy, and has diabetes. And she's got, I can show you a picture of the x-ray, but terrible medial knee osteoarthritis, to the point where, now she's not able to really bend her knee at all. Obviously, in somebody younger and maybe a little bit healthier, knee replacement would kind of be her ticket. But she also just recently got out of the hospital for COVID. So comorbidities, I mean, are you, from a practical standpoint, somebody like that, have you seen people benefit from the procedures?
Yeah, any of them really. And a lot of it, I mean, like I said, those last three, the cryo, the RFA, and the PNS, they're all basically the same patient. They're someone who doesn't want surgery because they just don't want it. They don't want to be cut on, or they can't get surgery or shouldn't get surgery because surgeons are worried about the bad outcomes and stuff like that. So I honestly, and I trained my PA to do this too, but we come in and we just kind of have a whole consult where we say, all right, well, RFA, here's what it is, here's the risk, here's the benefits. Cryo, here's the risk, here's the benefits. And then PNS, here's the risk, here's the benefits. What questions do you have? What sounds most enticing to you? Like, I kind of highlighted earlier, some people just like, oh my God, you're going to burn my nerve. Like they just can't even fathom that. Well, that's fine. We can do PNS. We're not even damaging your nerve. We're just going to stimulate your nerve. Or we can do cryo. And it is damaging your nerve, but it's reversible damage. And so I think it's educating the patient on, again, risks and benefits, how much is potential relief, and, letting them kind of make the decision, because it really is, and I have this conversation with patients all the time, but it's elective medicine. It's you can sit there and be in pain, and that's fine, I tell people all the time, I'm not a cancer doctor, so I'm not telling you have cancer, take this or you die. It's, here's your options. These can help you with pain. And if you don't like any of them, that's okay. But I don't recommend that you start taking opioids and you have all the dangerous side effects that has. So that's why I think I tell patients, if you're making decisions to not do stuff with family or whatever, then you might want to consider to do one of these things, because they are continually showing good results. And like I said, it's not always 100%, right? But, again, 50% relief, that's significant. So I think that's important, kind of reframing people's mind work a little bit about, like, everyone comes to the doctor expecting to be in no pain, but unfortunately we get to certain points, 87 years old, she's probably been in pain for quite a while. And so, again, we're going to try to make it all go away, but if we can at least do the best we can, hopefully that'll allow her to have a better quality of life, for however much life she has left.
I guess follow up to that, have these procedures, say, allowed a patient who, I guess, couldn't tolerate therapy before, does it get them to therapy? And have you seen any benefit to like procedure and then like therapy as an adjunct?
Yes, for sure. So I always tell patients that everyone's treatment option in at least my world is physical therapy. It's just a matter of, is it physical therapy alone, or do you need surgery before physical therapy, or do you need me to do a procedure before physical therapy? Because all these patients that come into you, if it's a back patient, they have core weakness. They have, fat atrophy potentially in their back, where their muscles that posteriorly haven't been used. Their core, like I said, core's weak, their glutes are weak, their quads are weak in knee patients, glutes, all that stuff. So, therapy always needs to be in the mix. It's just a matter of, if it hurts too much, then you need to do a procedure or something to help you tolerate therapy. And, a lot of times it's a steroid injection. They have some bursitis and a disc herniation, so we do an epidural, we do a troch bursa injection, and they can do therapy and they get better. But those patients that, steroids aren't a good option, or they've failed those, this fills that gap of that gray area, like I said, of patients who, have gone to the orthos for years, and it's like, well, we've done enough steroids and you can't have surgery, so here's some opioids. That shouldn't be the option that we're giving people. We should be giving them more options like this to help them feel better. And then hopefully, and I'll just say this real quick. So I saw a patient, or it's actually the husband of one of my PTAs. He has had 4 back surgeries, 4-level fusion. It's awful. But he gained a bunch of weight, and he saw all these doctors. He's been on chronic opioids forever. He finally came to see me, and so I examined him, and he had just arthritis above the level of his fusion, and I did a RFA, helped his pain. He still has some chronic radic pain, which will never go away, because he had the surgeon hit the nerve when he was doing like a fusion or whatever. But he can deal with his radic pain. The pain that he was actually having that was really bothering him was the arthritic pain that had developed above the level of fusion. I RFA'd him. He's now down 40 pounds, back to walking his dog, and he thought he was never going to go on a vacation with his family. He's going on a vacation next month with his family. So, again, it's about reframing what's your goals and educating people that we can't always make everything better, but what's really bothering you, and if we can help that motivated him to lose weight, which is ultimately going to hopefully give him more, years of life. So,
I guess last question, any utility, and I know you're using these as pre-op for like knee replacements and that kind of thing, but say athletes who need like an ACL repair or something like that, have you seen any results or used it in those kind of patients?
So we've talked about it in our practice, and we would like to do it. We haven't done it yet, but we do offer it sometimes. But the problem is, so in Georgia, like the cryoneurolysis, it's only covered by Medicare currently. So actually, probably like 60-70% of my practice is cash pay for for the cryo portion, because, a lot of people that aren't 65 get knee replacements. And because that we've been doing it long enough and my surgeons tout it highly, we get a lot of people, and also I live in Atlanta Metro, so there's quite a bit of people that have the money to pay for the procedure. So,
What's the cost?
so if you do, we have like two options. If you do the superficial only, so that's for like incisional pain mostly, it's $600. And then if you do we call it Cadillac, superficial and deep genicular, it's like $1,300. So not super unreasonable, I don't think, for what they're getting. And, three-ish months of relief is pretty cool, like, and not taking opioids, so.
Is there a role for doing PRP injections in a primary care clinic? And if so, are there any courses and product suppliers you might recommend?
I think there can be. You just want to make sure you know the data, and you know when it's appropriate, when it's not appropriate. And at least for my personal opinion, I think you should do it under guidance. I don't think you should do blind PRP injections. If you're making people pay for a procedure, you should be able to guarantee them that it's in their joint or it's in their tendon or something like that. And I think, it definitely would help if you had some sports training for sure. And just because you want to make sure you know those protocols, and, when you do it in a joint versus when you do it intraosseous or when you do it in a tendon, that protocol looks very different. And if you don't know it or you don't educate the patient on it, your outcomes aren't going to be very good, because you can get, for example, you can do it in a knee and get a kid back playing a lot quicker than you can in a patella tendon, which is pretty obvious why that is the case, I'm sure. But I think there's probably some roles. You just need to make sure you have the knowledge that you need to have. And, if you do a sports fellowship or, go to AMSSM and really focus on the PRP side of things, and the whole, which supplies or company. I think that's mostly driven by the hospital that you're employed by usually. So we use Arthrex at mine, but it's not because I think it's the best, but just what we have. There's definitely Insight and other ones that are really good. But again, it's like a financial cost question, I think. And I think if you just got to educate your patients again on what they're getting. Is it 3 times the amount of platelets? Is it 5 times? Is it 15 times? Studies show more is better, all that kind of stuff. So you just, like I said, you just want to educate your patients, I think, and make sure you feel comfortable doing it. One of my mentors in residency always told me, you should never really do a procedure that you're not comfortable doing, because that you're just setting yourself up for failure. So, I think there's potentially probably some roles, but you just want to make sure, like I said, you feel good about it before you do it, I think. Does that help? Is that a good answer for you? Okay. That's good.
Hey there. So kind of similar to Kevin, have a family member coming up with a total knee here soon. I know it was in the lecture. How soon before the total knee do you usually start thinking about cryo?
So it's usually recommended 2 to 3 weeks, because while iron degeneration is 3 to 4 weeks is what we think it takes. So you want it to be completely in effect before the surgery, and then they still have a good couple months after the surgery to get relief. So that's kind of what we do in our practice is 2 to 3 weeks usually.
Have you ever had to redo it after the total knee, say after that next 3 months is up and they're still having some pain?
So I never have, and like I said, I do work with the company that owns it, so I have a lot of connections with other doctors in different states and stuff that do it. Some it's done it longer than me too. I've found, and what my colleagues have found too, is they most often, it's again an education thing. This does not make all their pain go away, right? So we can do superficial nerves and we can do genicular nerves, but the knee innervation is quite complex. So we can't hit them all, and we can't denervate tendons either. So what we have started telling patients is you'll still probably have some pain after your surgery, but we can help either eliminate or really decrease your incisional pain. And those nerves that, the superficial nerves actually innervate the joint capsule as well. So it can actually help joint pain itself. And then the deep genicular nerves help also with the joint pain. So what we see most often, to answer your question, is we see people come back, oh, it didn't work, I have pain, and then they point, oh, that's your pes bursa that hurts. So we can't make that not hurt, or that's your patella tendon that hurts, or that's your VMO that shut down that needs to do therapy, and you're having lactic acid buildup and soreness from that. It's not a perfect treatment for sure, but I've never found, in any of the colleagues that I know haven't had to per se repeat it. Except, if it's like 3-4 months out and then they liked the relief they got and they wanted to repeat it, but not to like, because it stopped working, or something like that. I mean, and again, sometimes people may get 2 months, but I've also had people get 4 months. But we still tell people 3 months because that's what the physiologic effect is geared towards. So, and one last thing I'll say, it also depends on where you block the nerve. So if you block nerves up higher, it lasts longer because the damage started up more proximal. So it also depends on how high you do the procedure.
So you said you've talked to a lot of your colleagues and from different states. So do you have a list of people that we can go to that are maybe closer to us than 4 hours down to Georgia?
So if you go to their website, they have, like most companies do, the physician finder. I'm not sure, I don't know anyone personally in Tennessee, but yeah, just go to the iovera website and look up the physician finder, and they'll tell you who's doing that specific treatment in the area.
Any other questions for Dr. Gwynn? Okay, we'll take a short break and restart at 9.
Thank you.
All right, we'll get restarted here. Dr. Ellie Riley is the Senior Associate Program Director and Assistant Professor of Family Medicine at the University of Tennessee Family Medicine Residency Program in Jackson, Tennessee. She also serves as the Rural Site Director for the residency in Martin, Tennessee. Dr. Riley obtained her Doctor of Osteopathic Medicine degree from Kansas City University. Please help me welcome Dr. Riley.
Thank you. Good morning. I have a little bit of a cold, so hopefully I don't cough too much during this. I am glad to be here. I'm glad that this is my third, I think, LMU clinical thing conference, and I kind of feel like an LMU grad wannabe. Miss my osteopathic peeps, and so I try to hang out with y'all. I appreciate you inviting me to speak today. I did not get... Which do I press to advance? Thank you. So no disclosures. We're going to talk this morning about neurodevelopment, really to set the stage for why adverse childhood experiences are so very important. Talk briefly about the research related to that, and then really talk about what we all can do in our communities and our practices to try to mitigate the adverse health impacts of ACEs. So Building Strong Brains Tennessee is a private-public partnership that puts on these educational programs. They actually train people like myself to go into the community and talk about ACEs and the health impacts of ACEs, not just to physicians and healthcare providers, but to really all citizens throughout the state of Tennessee. And it's really about changing the culture of Tennessee so that we can put into place policies and programs that will help prevent the health impact of ACEs. So healthy child development really is the foundation that sets these important 4 pillars to provide successful parenting of the next generation. So healthy child development will lead to educational achievement, economic productivity, responsible citizenship, and lifelong health that prepares people to be good parents, which ultimately leads to strong communities and a healthy economy. And this is not just opinion. This is based on social science, neurodevelopment, molecular biology, genetics, and even looking at capital investment. So the brain architecture does build strong foundations, which then moves on to allow children to develop the important cognitive functions that they need to make good decisions later in life. So is anybody building a home right now? Okay, one brave soul in the back. We've been talking about it for 5 years. COVID put us, set back a little bit, but what's the first step in building a home? Even if you're not building one, you know that probably. I heard some whispers of foundation, that's right. And if you don't have a strong foundation, what are some signs or symptoms that your house might show you in years later? Cracks, leaning, maybe leaking roof. Just like building a home, the brain really needs a very strong foundation. The body needs a strong foundation. And if it doesn't lay that strong foundation in the earliest years of life, then that can actually lead to, in the human body, things like addiction, inflammation, cardiovascular disease, cancer. So the early years of life are the most critical point of building that strong foundation. There's a lot of players in building a home too, right? It's not like one person goes and puts up the entire home and does the plumbing and the roofing and the electricity. So there's lots of players too that build the strong foundation of a child's brain that leads to a successful, healthy life. Do we have any neuroscientists or neurologists? I'm a family medicine doc. I am no neuroscientist. I am no radiologist. We're going to touch on some of those things today, but I always like to put a little disclaimer that I am not necessarily an expert in these. But more than 1 million new neural connections are made per second in the first few years of a child's life, and by 3, 85% of that brain volume is developed. And this is critical. The other part of developing all these new neural connections is a process of pruning. So as a child experiences repetitive things in their life, it starts to want to reinforce those neural connections that are repetitive and actually prune away things that are not happening repetitively. And this is important because if a child has very good, strong, positive interactions with another adult or another human, then those connections are repetitively connected and reinforced. This is a problem, though, too, if a child is experiencing really bad, neglectful, maladaptive situations, because those are the things that are reinforced in a child's brain, and the positive experiences that they may be minimally experiencing are then pruned away. So serve and return relationships really support skill learning, and they're the things that help build those positive neural connections that build a strong foundation of the brain so that the child can then go on and develop important skills to help grow into healthy adults. So these serve and return interactions, you guys have seen it. Dana and I were talking about our young child. I have a 2.5-year-old, she's a 3-year-old, and we have all experienced that fun back and forth with a young child. They look at you, they smile, you smile back, you can't help but smile back. They may, look at you and coo or babble, and as grown-ups, sometimes we might wonder, why am I talking like this back to this child, this cooing and babbling, this nonsensical stuff? It's actually really important for their brain, that back and forth serve and return, to develop those skills. And it's not just us as parents that do it, but it's other people in the community. So it's grandparents, it may be early childhood or early child care teachers, it may be neighbors, friends, siblings, and then as they grow older, teachers. Those people all also help to develop strong foundations in the brain by allowing serve and return interactions to build those skills. And those are so important and vital to lay that foundation. If those things are not there, then the stress that we all experience as a natural part of life can become overwhelming to those children and break down the foundation. So just as in laying a foundation in a home and building a home, things happen kind of from a bottom-up sequence. The bottom of the graph, I do want to say, the first half of it on the left is expanded. Those are all months, and then you jump to years. But you can see that all of these neural circuits develop initially prenatally. We know that. The brain is developing prenatally, and those first few months and years are so critical in growing those neural connections, starting with just the sensory pathways, vision and hearing, and then building on top of that is language, higher cognitive functions, and then you see self-regulation really is the last thing that happens in adolescence, even in early adulthood. We probably all have experiences with adolescents maybe who don't have great self-regulation skills. We're all developing those well into our early adulthood years. But then you also see the drop-off that happens, and that's the natural pruning that is happening in the brain. So toxic stress, we're going to identify and define toxic stress, but it really disrupts brain development. So as important as serve and return interactions are in developing that brain and building a strong foundation, if children experience toxic stress during that critical brain development, it can really derail the brain's ability to lay a strong foundation. We all know that some stress is good. Our bodies need some stress, and that can help us to develop skills to self-regulate ourselves. Positive stress, like standing in front of a room of strangers, can cause our heart rate to go up a little bit, our blood pressure to go up a little bit, but with our self-regulation skills, that helps those things to come down. In a child's life, some positive stress examples might be getting a vaccine or getting called out by the teacher. Adults in our lives help mitigate those toxic stress response or those positive stress responses, and even more so the tolerable, more higher levels of stress. So if you think back to a time when maybe somebody in your life died that was important to you, the things that typically make those experiences easier are the people that we love, the people that help surround us and support us and lift us up and carry us on. But if a child does not have a positive adult in their life to help mitigate that stress, that's really what toxic stress is. It's the high levels of stress that are ongoing without the support of another human to help buffer that stress and bring those stress levels down. So physical or emotional abuse, exposure to violence, those are very stressful things. But again, toxic stress being those things combined with a lack of another human to help mitigate that. Again, I'm no radiologist, but this is a PET scan, and it's to demonstrate the differences between that of a healthy child. There on the left, these are both 3-year-old children, and that of a 3-year-old who was raised in a Romanian orphanage in the 90s. So apparently, Romanian orphanages in the 90s weren't the best sort of situations for young children. They were understaffed. They had staff that oftentimes did not have great education and development in child development, and they didn't really understand the importance of those serve and return interactions. And as a result, many children in Romanian orphanages suffered neglect and didn't have those positive experiences to reinforce the development of the brain. And as you can see, in the temporal lobe specifically that help regulate emotions and sensory input, there's definitely a decreased activity. Again, as a family doctor, I can interpret that more black and purple colors there in the temporal lobes. In the abused brain, what's labeled as the abused brain versus the healthy brain of the 3-year-old who did grow up in an environment where they experienced positive serve and return interactions that help build that healthy foundation. So what are some common sources of toxic stress? I mentioned a few earlier. This graph really depicts maltreatment here on the left, which according to this data, about 75 per 1,000 U.S. children between the ages of 2 and 5 experience that. This is a study done at Harvard in 2007. And maltreatment, if I can reference my notes, specifically with neglect, physical abuse, sexual assault, psychological abuse, and parental custodial interference. So we know that maltreatment is definitely can be a source of toxic stress, but not necessarily the most common thing that kids experience. So many of the kids in my practice and probably in your practice may be suffering from parents who are suffering postpartum depression or parents who are experiencing parental substance abuse. And those things by definition are not necessarily maltreatment. Okay, but they can lead to maltreatment. They can lead to neglect. They can lead to physical abuse or emotional abuse. And those are things that we certainly have some resources around, and we have some opportunities to mitigate those so that they don't go on to maltreatment and become sources of toxic stress for children. Intergenerational transmission of toxic stress is an issue as well. So if you can imagine the child who maybe experienced some ACEs, which we're going to define and talk about more here in a minute, but they develop, we know, dysregulated stress response because of the brains, the change that those brains experience early in life. And that increases the risk for addiction and mental health problems. We've talked a lot about, opioids and addiction the last few days, and it really did not go past me that it is much related to ACEs. Can't read what that says. Impaired response to infant cues. So the parent who is experiencing addiction and mental health problems is not going to as easily respond to their crying infant or their crying child, and in turn may lead to habitual behavior. So the child is actually stressing them out, and they don't have those good cognitive skills to cope with those. They don't have great coping mechanisms. And then in turn, they are causing ACEs to their child, and it just intergenerationally transmits. So epigenetics is really a fascinating field of medicine and research in which the expression of genes are changed, but the genes themselves are not changed. And this is one way that we know ACEs can be passed on from one generation to another. There's a study that was done at Emory in little mice that explains this intergenerational transmission in epigenetics. So these Emory researchers took male mice, and they taught these male mice to fear the smell of cherry blossoms by shocking their little mice feet. They were mild shocks, but shocking them every time they smelled a cherry blossom. And then 2 weeks later, they bred these male mice with female mice, and then they took their mice children and raised them into adult mice. And without ever exposing the mice, the children mice that were now adults, they then let them smell cherry blossoms, and those mice became fearful and anxious, very similar to what their fathers experienced. And then they bred those mice again and found that in that second generation, those mice also became more fearful and anxious to the smell of a cherry blossom versus that of a neutral smell. They also looked at the amount of neurons in the nose that were specific to cherry blossoms and found they had more cherry blossom neurons in their nose related to those that were not exposed to that or in that direct line. And they also had more space, brain space devoted to smelling, specifically cherry blossoms, than those control mice. Then they took a whole nother section of mice, and the female mice, they wanted to control for any possible social interactions, and they inseminated these female mice who had no exposure to these male mice, the initial male mice, and found similar in a similar study. So getting to adverse childhood experiences, and I think my next one is a video that will kind of summarize a lot about adverse childhood experiences.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
So, as you heard, ACEs can have lasting effects on health and behavior, lifestyle, and really it affects all of us as a community. The ACE score of 4 or higher seems to really be the tipping point for people to experience health and behavior issues secondary to ACEs. The primary researchers actually came up with this pyramid to show that there's lots of different things that will predict disease, disability, social problems, and early death, but at the base of that really is those adverse childhood experiences. You can think of this little pie wheel as the black spot, at least in the middle, is a percentage of each of those diseases or issues that is contributed to ACEs. And if you were to take a paper towel and soak up those ACEs, if you had public policies and programs that would help diminish the health effects of those ACEs, you could absorb and relatively reduce the percentage of each of those issues, those health issues, by addressing ACEs. 30 states across the nation have looked at the prevalence of ACEs in their communities and in their state populations. Tennessee is one of those. 61% of Tennesseans back in 2017 had at least one ACE, and more than 1 in 4 Tennesseans have 3 or more ACEs. And this is a huge economic impact on our state, on our patients, on our families, costing $5.2 billion in medical and work-related issues. And that's just based on 8 of these ACE-related health outcomes and behaviors: smoking, depression, cardiovascular disease, obesity, diabetes, COPD, asthma, and hypertension. So this is not a hopeless sort of situation. The first time I heard about ACEs was when I was in practice. I was shocked. I was horrified. I didn't know why we weren't all talking about this all the time. and I felt like really helpless as well, like there was nothing to do. And that is not the case. I am going to skip this video, so can I do that, or do you have to? You'll do it? So we really need to look at this as a public health crisis. ACEs is the biggest, I think, public health crisis facing our nation and probably our world. And public health crises require public health approaches. And really, primary prevention is the way to go, right? We all know that as medical providers. So creating safe, stable, nurturing relationships and environments and community infrastructures that will help promote that social cohesion does primarily prevent ACEs. But unfortunately, we tend to spend a whole lot of money on the back end, right? We've talked again about addiction services, mental health services. Those are all super important, but we could probably reduce the amount of money we spend on those resources if we really look at spending our money in the early stages of life and helping support families. We know that positive childhood experiences help to buffer ACEs and promote adult health, and specifically 6 or 7 positive childhood experiences lowered the likelihood of depression by 72% in people who had high ACEs. So for our adolescents, that's really a critical time as well. The brain grows a whole lot in the first couple of years of life, but it's really malleable also during the adolescence. And so it's important for us not to forget about our adolescents. And these things all help promote executive function skills, coping mechanisms, and these are excellent resources that would help mitigate ACEs. Across the lifespan, things like adopting trauma-informed schools, we know that evidence-based home visiting programs do help specifically to mitigate the adverse health effects from ACEs. Integrated health care, high-quality, affordable childcare, that really takes the stress off the parents, and so that they're better able to cope with their child, especially if they've experienced ACEs. Business and organizational policies that help support working parents. And I'll skip through some of this. So on the TCCY Tennessee State website, you can actually look at your county and see how well your county is doing. They look at economic well-being, education, health, and the family and community. I just pulled up Sevier County, found that they are ranked 61, and they're looking at things like child poverty, child and teen deaths, pregnancy, 3rd to 8th grade reading proficiency. This is the health of the child in Sevier County. So you can look up and see how your county is doing and maybe what opportunities are there for you to help talk about these issues and support your families and your community stakeholders. So really changing the conversation to what is wrong with you, which we often say, right? We know that blame and guilt does not move the needle. But really asking what has happened to you and how can we help. I know I'm a little bit over, so if you'll just take a quick picture of that and go to that link. The Building Strong Brains program does want you to evaluate me. I know you're going to evaluate me for the conference. This is separate for their program so that they can know where this information is getting to and apparently how well we're doing at it. So thank you.
And we will have a time for questions for Dr. Riley after the next lecture. So I will go ahead and introduce Dr. Landon Harrison. Dr. Harrison received her Doctor of Osteopathic Medicine degree from LMU-DCOM and her Master of Business Administration degree from Lincoln Memorial University in 2013. She completed her OB-GYN residency at Mercy Health. My phone's acting up on me. Mercy Health St. Vincent Medical Center in Toledo, Ohio. She is currently an OB-GYN at Parkview Regional Medical Center, Parkview Physicians Group in Fort Wayne, Indiana. Dr. Harrison is a member of the American College of Osteopathic Obstetricians and Gynecologists, the American Congress of Obstetricians and Gynecologists, and the Indiana State Medical Association. Please help me welcome Dr. Harrison. Use either one, and then the green button here will move forward.
Okay. Hi. So yeah, she did a great job. Oh gosh, my friend's taking my picture over there. Okay, so they asked me to speak, and they said at a lot of previous conferences, some of the feedback that they had gotten said people wanted to learn more about contraception and birth control. So for some of you, it'll be a great topic. Most people either like learning about it or they're like, I don't want to touch anything GYN related at all. So I made it pretty general, so hopefully everybody can pick out a couple things that's helpful to their practice, or at least get them to start thinking about some things to research. So this is a chart. I have one of these in each of my office rooms. It's from the CDC. I really like it because it shows all the methods of birth control, medical, non-medical. So I like to pull it out and have my patients reference it if they're really kind of unsure of what they want to do. We're going to be sticking with the reversible ones, the ring, the patch, the pill, the injectable, an IUD, and an implant. And it's nice because it breaks it up because it shows you that your ring, your patch, your pill, your injectables, they're pretty good at preventing pregnancy if they're used like they're supposed to. The best are an IUD or an implant, with the next one on implant actually being the best. So I kind of broke it down into hormonal birth control versus non-hormonal birth control. So we're going to start with the ones that have hormones first. The most common one being your combined oral contraceptive pills. There's thousands and thousands of them out there. The ones I use, honestly, it's because when I started, those were the ones that the reps dropped off at the office the most. So that's kind of how I got used to prescribing the ones that I do. I do go outside of them, the more used of, the ones that I'm using. But when prescribing one, like most medications, you want to try and use the lowest dose of the hormones possible to achieve the effect that you want, whether it be, emotion control, bleeding control, pain control, things like that. You want to make sure they're well tolerated by your patient. Affordability is a big one. Of course, a lot of the ones I like, insurances don't cover. So you have to, sometimes you send them to the pharmacy, they call back, oh, insurance doesn't cover these. So then you have to find one that's affordable for the patient. There's a lot of other non-contraceptive benefits that your birth control pills can offer that you like to think about. The first one, acne and hirsutism. There are 3 FDA-approved birth control pills for those: orthotricycline, estrostep, and Yaz. I probably use orthotricycline the most. I've never used estrostep, but Yaz is always a very popular one. Abnormal uterine bleeding, patients who have really heavy periods, they pass clots, they have bleeding in between periods. Obviously, after you've done an appropriate workup to make sure that there's nothing else going on, they can do really well on birth control pills. Patients who are going through perimenopause, patients who are 45, they're starting to get hot flashes, night sweats, moodiness, weight gain, low libido, things like that. They can be on a birth control pill. Average age of menopause is 52. You can keep them on until 52, 53, 54, and then take them off birth control pills if they want, just to help them feel a little bit better. Pelvic pain, endometriosis, they do a great job of helping those symptoms. A lot of times for endometriosis, if it's really bad, I have patients, they'll take a pill continuously where they don't even have a period, so they don't have the cramping and the pain and the bloating and things like that. Your premenstrual syndrome, dysphoric disorders, the one approved for that is Yaz. I'll talk a little bit about how hormones are in these pills, but Yaz is what we call a monophasic pill, so it gives you the same amount of hormones all month. So that's really good for people that have a lot of period-related, like depression, anxiety. They're the ones that come in, my teenage daughter's in her room crying 2 months or 2 weeks before her period, then gets her period, everything's fine. Yaz is a good one for that. So the pills are broken down. You have monophasic pills, biphasic pills, and triphasic pills. Like we just talked about with Yaz, your monophasic pills have the same amount of estrogen and progesterone for 21 days. And then you have that period-free week or 4 days when you have a period. Biphasic, it's split. You have the same amount of estrogen and progesterone for a period of time, then split, then you have your change. Some pills have the same amount of estrogen. The progesterone varies. Some have varying progesterone and estrogen. Your triphasic, it's split up into 3 doses. I don't think I've ever used a biphasic pill. Most people do monophasic or triphasic. They developed these biphasic and triphasic pills because they thought it would help with the symptoms that people are having sometimes with birth control pills, like the breast tenderness, emotional lability, things like that. They haven't really found that it helps too much with the side effects. There's also no difference in effectiveness. So your triphasic pills are the same amount of effectiveness as the monophasic pills. They also come in different doses. You have high dose pills, low dose pills, and then your ultra low dose pills. High dose pills are usually those that have 30 micrograms of estrogen or more. They actually go up to 50 micrograms. And when I was doing this presentation, that's what they actually started as. No one gives a 50 microgram birth control pill. That is way too much estrogen for birth control. It is usually used for things like abnormal bleeding, other things that's not contraception. Your low dose pills are those that are between 10 micrograms and 35 micrograms. Those are probably the most common used and the ones that I start with on a patient who comes in saying, hey, I think I want to do birth control. I'll start with usually a low dose pill for them because then I can go up in my hormones if I need to. I can go down in my hormones if I need to. Your ultra low dose pills are those that have 10 micrograms or less. A really good example of that one would be low estrin. It's one of my favorites. It is hard to get covered by insurance though, because there is no generic, it's only brand name. You can give them to patients or they come in different ways to take. So cyclical, that's like your conventional, where you have your active pill for 21 to 24 days, followed by a 7 to 4 day hormone-free. Extended is where you have active pills for 3 months, followed by, that should be 7 days of hormone-free. That would be like your seasonique. And then you have continuous, where you would have a patient take active pills for every single day without a break. Again, usually for things with people like really severe endometriosis or pelvic pain. Birth control pills, most of the mechanism of actions are all pretty much the same for all the contraceptions. The main thing they do is prevent ovulation, they thicken cervical mucus, and then they change the endometrium. For side effects for all the birth controls that I'm going to talk about, it's greater than 10%. Every side effect you could think of imaginable is listed for birth control, but all the ones I listed are ones that people complain about greater than 10%. So for pills, nausea and vomiting, breakthrough bleeding, headaches, and migraines. This is a really good chart off the CDC. I mean, everyone knows the general contraindications to, estrogen and progesterone birth control, but this is really good because you go in, you search a condition, and it has a nice color-coded and numeric code for if that birth control is acceptable, if it's not, if it's contraindicated, things like that. The next type of pill are progesterone-only pills, and the 2 main players here are your norethindrone progesterone and then your drospirenone. The norethindrone typically is referred to as the mini pill, which everyone's probably pretty familiar with for like postpartum, things like that. There's no hormone-free pills in that. It's all the same. And then your drospirenone is 24 active pills, 4 hormone-free pills. Norethindrone has a pretty short half-life. The drospirenone has a longer half-life, which is good. If someone needs to be on progesterone only and they find that they're having a lot more breakthrough bleeding, things like that, a lot of times they'll put them on the drospirenone because of the longer half-life, so that'll improve. It's also a spironolactone analog, which is really nice if people need it for things like acne. Mechanism of action of progesterone pills, again, they change cervical mucus, change your endometrium, and in some people prevent ovulation. Side effects with these: headache, breast tenderness, nausea, vomiting, acne, hair growth, and depression. The Depo-Provera is your progesterone injection. You get that dosed every 3 months, and they recommend for a duration of no more than 2 years, which I'll get to in a second. mechanism of action with the depot. It suppresses ovulation and actually estrogen, and it thins your endometrial lining. So that estrogen suppression is why they write don't use it for more than 2 years. ACOG's stance is a risk versus benefit. If you need someone to be on it longer, it's fine. Again, you just kind of have to consider your patient population. If you have a 10-year-old, who's in a critical area of bone formation, things like that, I would not keep him on it for longer than 2 years. I had a patient, she was 48, and I think she had been on it for 13 years. And I was like, wow, maybe we should get you off of that, for bone health. But when I tell that to most people, they're fine with it because there's so many other options to go on. And I always kind of phrase it like the bone loss that you have with depot is kind of the same bone loss that you have when you're pregnant, when you're breastfeeding. It's only for that limited time, and when you stop, everything should kind of come back. Side effects with the depot: amenorrhea, hot flashes, weight gain, weight loss, breakthrough bleeding, headache, and nervousness. When I bring up the depot with people, everyone is always like, oh, but I hear about weight gain. I think I'm going to gain weight. I have 17 friends on this, and they've all gained 50 pounds. Statistically, that's not true. Most people will gain a pound or two the first year you're on it, and then maybe they wrote anywhere between like 4 to 10 pounds the remainder of the time, but they can't correlate that with if it's actually the medication or just lifestyle and how people gain weight throughout the years. Your birth control patch, the most common one is Xulane, both estrogen and progesterone. Again, same mechanism of action, prevents ovulation, thickens cervical mucus, changes your endometrial lining. You have a patch, you put it on once a week for 3 weeks, and then you have a patch-free week. You can wear this on your abdomen, your lower back, your buttocks, your upper outer arm. They say don't use if your BMI is greater than 30, just because they don't know if it works as well if you have a BMI over that. Side effects: headache, breast changes, nausea, site reaction. In researching this, there is also another one. It's called Twirla. I didn't know there was another one. Apparently we don't have a rep in our area maybe. But again, it's the same mechanism of action, same everything. It's just another brand. The birth control ring. I always tell my patients I really like this one. It's really good for people that don't want to take a pill every day, yet don't want an implantable device like an IUD or a Nexplanon. It's estrogen and progesterone. It's a ring. You place it vaginally for 3 weeks, remove it for 1. So it's really nice. You put it in, don't have to worry about it for 3 weeks. Take it out, have a period, put a new one in. The NuvaRing, you do have to refrigerate it. So some people don't want that in the refrigerator, but it is refrigeratable. That used to be the only one until recently. They came out maybe in the last year or two with one called Anovera. Estrogen and progesterone also. Place it vaginally for 3 weeks, remove for 1. So same routine there, but it is annual. You don't throw it away after you're done. You leave it. You can use it for an entire year, an entire 13 cycles. Differences in those are just basically size. The NuvaRing is a little bit more slender. The Anovera it's a little thicker. So some people don't like that. Again, same mechanism of action, prevents ovulation, thickens the mucus, changes on endometrium. Side effects: breakthrough bleeding, vaginitis, and headache. Again, all the things, vaginal or intrauterine. Some people have more vaginal irritation or discharge with those. The Nexplanon, this is a progesterone-only rod. It inserts right there in your upper arm. You can see in that picture. Like I said, progesterone only, so prevents ovulation, changes on the cervical mucus, endometrial atrophy. Side effects: local. You can have some redness, hematoma, bruising, pain. I had one patient about a week after she actually got numbness and tingling in her hands and her fingers. So that's rare, but we had to take that out and then it went away. Systemic breakthrough bleeding. I bolded that one because we're going to talk about it a little bit. Amenorrhea, a lot of people like that. That's a positive side effect that you might not have a period with it. abdominal pain, weight gain, acne, headache, and pharyngitis. I have no idea on that, but that is a documented side effect in greater than 10% people. And then I actually Googled it, and yeah, it's true. I don't know where that comes from. I've never had anyone complain about it. It's super easy to insert. I remember one of my first patients ever as an attending came in they wanted an Nexplanon for their daughter, and they ran to my office and YouTubed how to do it because I had no idea. It's super easy. I put most of these in probably like teenagers, girls that are in their early 20s. They get really nervous about it because it's kind of a procedure, but the lidocaine's the worst part. So breakthrough bleeding is fairly common with this just because it thins your endometrial lining so much. There's a lot of atrophy there. So things you can do, patients can take a course of some NSAIDs for a couple of days. That will help. I sometimes will either prescribe or give them a sample of birth control pills, and they'll take the first 3 active weeks to give them back a little bit of that estrogen. Works really well, of course, if they have no contraindications to taking estrogen. They can just take some straight estrogen, 1 milligram, for 10 to 20 days. I usually do 7. I find that sufficient. And I have a friend, I just wrote this in because I was kind of asking everybody what they did. She does 2 milligrams of estrogen for 10 days and says that works really well too. Most of the time, if I preference patients, hey, you might have some breakthrough bleeding for the first 3 months, and this is what we can do for it, it doesn't really bother too many people. I think a gynecologist's favorite birth control right here, the IUD, they're amazing. So everyone should learn how to do these. The first one is the Mirena, which everyone's probably the most familiar with, has the most amount of progesterone in, recently approved for 8 years for pregnancy and 5 years for bleeding. So it's both FDA approved for birth control and abnormal uterine bleeding, they all are, but that one can be left in the longest. It is the biggest at only 1.2 inches. Then the other kind of sister device is the Kyleena, has a little less progesterone in it. The duration is 5 years, like I said, a little smaller. Skyla is the smallest one, least amount of estrogen, and has a duration of 3 years. They're all equally as effective, so you just have to talk with your patients and kind of figure out which one's going to be the best. If you have a mom, she's had 3 kids vaginal, she comes in, she doesn't want a tubal, something long term, but she wants an IUD, a Mirena would be no problem. If you have a little 22-year-old coming in, she's never had a vaginal delivery, something like that, I usually stick with the Kyleena or the Skyla because they're smaller, easier to insert and tolerate. Again, the IUD changes your cervical mucus, thins your endometrium, doesn't really always prevent ovulation though. Side effects, acne, that's a pretty common one, abdominal pain, bacterial vaginosis, vaginal discharge are pretty common in people, amenorrhea, breakthrough bleeding, pelvic pain, headaches, ovarian cysts. This is kind of an important one to remember. Because say you have someone who gets a lot of ovarian cysts, they go to the ER, they always get told they have a cyst rupture, they get pain from cysts. It's better to put them on like a combined birth control than an IUD. They don't do a great job at preventing those. Like I said, they're pretty easy to learn how to insert. I usually have people come in when they're on their periods. It just makes it easier because the cervix is already kind of dilated. And then 100% too, they're not pregnant. I tell everyone to take some Motrin, 600, 800 of Motrin before coming in because it is pretty crampy. You do not have to some people will do a gonorrhea and chlamydia test on patients before they put them in. You do not have to. If you're worried about it, if they're kind of an at-risk patient, you can. I've done it before and inserted them, and then their GCC comes back positive, and I just treat them, and I've had no problems with PID or anything like that. They can follow up in about 4 weeks to do a string check. Some people will I have some partners that bring them back for an ultrasound instead of a string check. You can do that if you like. If I have a harder insert, I'll do that, but a string check is sufficient. And when you bring them in, super easy. You just take the strings and you grab them and you pull them out. I unadvisedly have patients that just do this at home too. So it's pretty easy. If you can't see the strings, sometimes you do have to do it under ultrasound guidance. It's easier for us obstetricians because we have like 3 ultrasounds in our offices, so it's pretty simple to just take them over there. But you might have to take them to ultrasound to take it out there. I've taken a bunch out intraoperatively. I had a patient this past week. She's had her IUD in for 15 years, and now decided she wants it out. And we were in the ultrasound room for probably 20 minutes, and I couldn't get it out, so I have to take her to the OR, do a hysteroscope, take it out. I've also taken them out of the abdomen before. So again, breakthrough bleeding can be a common complaint. With the IUD, you always want to confirm that it's in the right place, whether with a string check or bring them in for an ultrasound. NSAIDs, like we talked about before, birth control pills for 3 weeks, or some estrogen if they can do those 2 bottom things. Non-hormonal birth control, the big one that everyone thinks about is the Paragard, the copper IUD. It's approved for 10 years. Mechanism of action is a little bit different. It works through, I want to make sure I say the right thing here. Oh yeah, the cytotoxic inflammatory response. It also impairs sperm migration, viability, and prevents implantation. And that last one is preventing implantation is why it's also used for like emergency contraception as well. And again, you can always reassure patients that even though it's like an emergency contraception, it doesn't prevent a pregnancy that's already there. People get concerned about that too. Side effects, heavy periods, breakthrough bleeding, pelvic pain, and anemia. It's always important to tell patients too, this one will not stop your periods like the progesterone-only IUDs will. You will still have a period. It might be worse. Now the copper IUD reps say no, but it is. But most people, if they have the expectation, these people are your people who can't take birth control pills or anything with hormones because they've had blood clots, because they don't want to, they don't like the way they feel. So for them, heavier periods, things like that is fine as long as they have the expectation of that's what it's going to be. Your regular contraindications with IUDs, bleeding of unknown origin, huge uterine septums, uterine fibroids, pelvic inflammatory disease, things like that. The other 2 that are important with entry with the copper IUDs, Wilson's disease or a copper allergy. Again, breakthrough bleeding with this one, confirmed placement, NSAIDs. That's pretty much all you can do. I know some people have done TXA, but most of the time these people, you can't give them estrogen or anything like that, so you can just talk about another option. Phexxi, I don't know if anyone's heard of this one. This one's pretty new. It is a birth control gel. You place it and you have 1 hour to use it after it's placed. You cannot have intercourse and place it later. You have to place it before. So it is made of lactic acid, citric acid, and potassium bitartrate. So that works. It maintains a vaginal pH, which lowers the sperm motility. I was trying to talk with the rep because when I was doing research on it, I found it effective anywhere from like 70 to 90 some %. He didn't get back to me. I've had 2 patients use this, and both have gotten pregnant. So, my research on that is not too good, but they say it works well. So, and one of them had twins 6 months before. So. Side effects with this one, vaginal itching, burning, BV, yeast infection, vaginal discharge. It's all kind of obvious because it's what it's made of. And then in researching, male partners can actually experience pain too, burning, itching, but it's described as moderate if that makes anyone feel better. So postpartum birth control, breastfeeding, we will do progesterone-only options so it doesn't decrease mom's milk supply. So again, pills, a depot shot, Nexplanon or the IUD. I usually have moms pick the pill. The next most common for me is usually an IUD. If they're formula feeding or they're not breastfeeding, adoption or something like that, they don't have to be kept to a strict progesterone only. Average return to ovulation is 45 to 95 days. Can happen as early as like 20 days postpartum though. You can do progesterone-only methods anytime after delivery. You don't have to wait. So people can get an injection of Depo postpartum before they go home. They can get an Nexplanon. They can get an IUD. That's just fine. We don't have those at our hospital, so usually we just talk about everything 6 weeks postpartum. But if you have a patient that you're particularly worried about, you can do that stuff before they go home. For your estrogen and progesterone birth controls, you're supposed to withhold those for at least 21 days in patients with a low risk for thromboembolism, or 6 weeks for a high risk. Nothing for 6 weeks, or I just put them on progesterone only. So you can, but most obstetricians will just stick with nothing or progesterone only. Lastly, this is a really good app if you don't have this on your phone, from the CDC. Again, kind of reflects back to that graph that I showed with the contraindications and what birth control is best for what condition. You can just click, hey, I want to know by condition what's going to be a really good birth control pill. So I clicked history of bariatric surgery up in this one with restrictive procedure. You click on that and it'll pull up right here in the middle. Your IUDs are good, your implants are good, your Depo's good. It gives you kind of a red 3 for your progesterone. Says your combined oral contraceptives are a 3, but the vaginal ring is good. And then if you want to know why, you just click on that plus and it'll tell you the evidence why and why you shouldn't use those. And that's it. Any questions? Danielle.
You answered most of my question about breakthrough bleeding on Nexplanon, because we do a lot of those. But we do the estradiol first, and then our OBs had said after that, if that doesn't stop it, to use low estrogen. But you said it's due to low estrogen, so that doesn't make any sense.
Well, if it's low estrogen, still has estrogen in it. The pill still does have estrogen in it. Yeah. So they're getting more than they would have originally.
Is that helpful? Is that something you've done, or do you have a?
I'll usually do the birth control pill first, and then I'll do estrogen if not. Usually that takes care of it, but you can do low estrogen, you can do any type of birth control pill. It doesn't have to be high dose, low dose, anything is fine.
Gotcha, okay, thanks.
With the different IUDs, do you notice a difference in the size? Like if someone had a hard time with like pelvic pain, even like ultrasound follow-up, everything looked good, placement was good, but they were having just intermittent pelvic pain with the Mirena,
Yes.
using a smaller one?
Yes.
Would it be worth a shot?
Absolutely, yeah. A lot of times, yeah, when they have pelvic pain, then you'll bring them in for an ultrasound to see, is it in the right spot? Is it doing what it needs to do? If they have a smaller uterus or a smaller cavity, I will try a smaller IUD, and a lot of the times that works.
How often are you using Liletta?
Oh, yes. So I didn't put that one in there. Never. Not because it's not good. That's another IUD. It's effective for 6 years. We just don't have it in our office. And I've actually, in residency, we didn't have it either. So that one is another one out there. Works just as well. We don't have it.
Could you do the extended or continuous dosing with the NuvaRing as well?
Absolutely. Yep.
I think we've run out of time for questions. If there are any other questions, then we can submit them to Amy Drittler and get answers on those. We can take a short 5-minute break and get started back.
for the sake of time, we're going to go ahead and get restarted. Dr. Cameron Shawver graduated summa cum laude from East Tennessee State University with a double bachelor's degree in physics and chemistry. He obtained his osteopathic medical degree from LMU-DCOM. Dr. Shawver then entered active duty service as an officer in the United States Air Force, during which time he completed his internship and residency at Nellis Air Force Base in family medicine. He went on to be the first Air Force family medicine physician to complete an interventional pain medicine fellowship at the Brooke Army Medical Center in San Antonio, Texas. He is double board certified in family medicine and pain medicine through the American Board of Family Medicine. He has served as the Associate Program Director for the largest pain medicine fellowship in the Department of Defense and was instrumental in training the newest generation of military pain medicine physicians. Additionally, he is fully trained in both medical acupuncture and osteopathic manipulation, as well as additional training in functional medicine. Please help me welcome Dr. Shawver.
Yeah, I don't like to stay in one spot. All right, well, is this on? Let's try it again. No? Yes? We'll try this one. Hello? There we go. All right, well, I have to apologize a little bit because the uncommon common pain syndrome, this was originally designed as like a 4-hour CME, but I kind of picked out the parts that I thought were more pertinent. So it's not going to sound exactly like uncommon common pain syndrome, I don't think, but I hope that we'll still get something good out of it, okay? I don't have any disclosures. Our objective today are kind of going to be twofold mainly, and if we have some time, I'm happy to go through some like non-opioid pain management. If people are really curious, we can talk about some opioid pain management too. But primarily, I want to make you guys experts in low back pain, okay? Number two, there's several disease states that benefit well from early recognition and early treatment, but tend to go undiagnosed for long periods of time. And so that's one that I'm going to put a little focus on. That's really the carrot for the uncommon common pain syndrome. Here's our outline. We're going to kind of go through these bad boys, and let's get started. So advanced low back pain. I don't know if you know this, but you're probably going to encounter low back pain regardless of what field you're going into, right? So why differentiate? I remember my background was in primary care, and so originally I kind of viewed pain medicine as like the referrals as a like, oh, I want them to have epidurals and then get put on opioids. Like if that doesn't work. It was just kind of this black box of medicine, didn't really understand what happened on the other side. But if I was able to differentiate a little bit better on my diagnosis on what's going on in the spine, then I would know what to expect. For example, in Vegas, I sent someone out for pain medicine and they came back with a recommendation for seaweed wraps and some other things. I mean, I didn't have to be an expert to know that that was a little kooky, just a little. All right, so we're going to talk about a few different areas of these vertebrae. I don't have a laser on this, right? Ooh. There we go. Oh, excellent, excellent. Okay, so this is a facet joint, also called a zygapophyseal joint. See, this is the only bony attachment of the vertebral body. The disc is going to be important, the vertebral body is going to be important, and these little foramen are going to be important. And then there's another part that we'll talk about in a minute. So we're going to start with technically the most predominant type of pain in young patients, okay? So this is colloquially known as discogenic pain. There's been some new technologies that have come out to target different areas of the vertebral body, so I feel like we've even gotten a little more specific than discogenic, so we can say, is it coming from the end plate? Is it coming from the annulus? Is it coming from... Well, those are pretty much it. But let's move on. So what does this sound like? So young patient, 30s, helped someone move a couch, heard a pop, woke up the next day, excruciating pain, goes away in a couple weeks. That's probably a discogenic pain. Now, a lot of times this is going to be accompanied by a radicular pain, because when these discs tend to pop, they get really pissed off. Remember, the nucleus pulposus is not an area of the body that usually gets blood flow. So if you get blood into there, your body's like, what the hell are these proteins in here? And so they'll go in, they'll attack it. You have this thing called a MMP cascade, and you have a whole bunch of inflammatory cytokines, and that's what pisses off the nerve roots. Typically not a true impingement, like we say a pinched nerve, but you have a inflammatory reaction in close proximity to a nerve, and so you get pain going down that distribution. All right, but we'll talk more about that a little bit later. So like I said, this person comes in. By the time they get in with the pain physician, usually it's already resolved, because it takes a couple weeks to get in, and 90% of these cases are going to resolve themselves within 6 weeks. We talked a little bit about like if you get a little end plate here, that plasmin in your blood activates these inflammatory cytokines. Those inflammatory cytokines start eating up the annulus, which will then cause it to kind of rupture, typically, in this kind of posterior lateral distribution. I don't know how many of you guys nerd out on your MRIs. I was going to talk a little bit about MRIs, and in particular, don't let your patients get too excited about them. There's very few MRI findings that actually guide the treatment. Meaning, like, if your symptoms don't match up with your MRI, I'm not going to be like, oh, well, we still have to do your epidural at this level because your MRI tells me that. So these are some of the things suggestive of discogenic pain. So if someone comes in with that midline back pain, younger patient, and their MRI has this button is right next to the laser button. High intensity zones, or these fancy things called modic changes, then you'd be like, maybe this is coming from the disc. So like I said, 95% of cases, these are going to be smack dab in the back, kind of deep, typically not reproducible with palpation. Forward flexion makes it worse, and on the next slide, we'll talk a little bit more about that. And there's a few other things that you can do. Valsalva tends to make it worse because it's increasing that pressure and then kind of poking on there. This was a rather cruel study done where they took a pressure reader and shoved it right into someone's disc, and then said, hey, do you mind doing some exercises for us and showing us what the inside of the disc does? So these are pressure readings from inside the disc of a patient in various states. As you can tell, laying down flat lowers the pressure in the disc the most. The worst thing you could do is kind of bending over, like here, herky-jerky, right? And then trying to stand up. Now, the bad news is, or congratulations, you've diagnosed discogenic pain. The bad news is we don't really have a gold standard treatment. This is one of those things, industry will put out something every, seems like, 2 to 8 years, and they'll be like, man, our data looks fantastic for discogenic pain. All of it paid for by, and so in real practice, you do it and it doesn't really work, and then they kind of fade off into oblivion. We do typically start with an epidural steroid injection, not because we think it's going to work, but because if it does work, it tends to work really well. Like the differential between not working and just working really well is only like 5%. And it's relatively low risk. And like I said, for most of these patients are going to resolve in 6 weeks anyway. So if this is an early one, you can kind of, instead of them being like 8 out of 10 for the next couple of weeks, you can cool it down while it already is going to heal up anyway. Next part, intradiscal PRP. This is one I was kind of interested in when I was in the military. We did a study on it, and it looks good. It looks good so far. There's only like 2 or 3 other studies on intradiscal PRP. But for these patients that have already gone through the MMP cascade, and because obviously we already talked, if you introduce plasmin in a healthy disc, that's less than good. So still a lot of research to be done on that, but it may be potential. Spinal cord stimulation. We'll talk a little bit more about this as the talk goes on, but in general, spinal cord stimulation has come a long way in approximately 2010 to 2015. They had a kind of technological revolution in the industry, and they've started using much different techniques than previously. And so if you have a patient that had a bad experience with the spinal cord stimulator, and then just ask them when, because a lot of times it's prior to that time frame. The reason I bring it up is, historically, traditional spinal cord stim is terrible for axial low back pain, but typically because by the time you crank it up high enough to capture this area, you get abdominal and rib discomfort. But with these other ones, they have these paresthesia-free based treatments. And so while not as slam dunk as like a radicular pain, which we'll talk about, significantly better to the point that we would, trial it. Basivertebral nerve RFA, this was something that's kind of, I think, on the way out, but similar to that, technology that comes around every 5 years that says, hey, this is going to be great. I did one of them before I left the military. You essentially go right through the pedicle into the vertebral body. There's a basivertebral nerve, which is a branch of the sinovertebral nerve that innervates the end plates in the annulus, the posterior, annulus. And you zap it with radiofrequency ablation. Goal is to obviously denervate it, but honestly, I don't see a lot of good results from that. The other good news is this will likely resolve spontaneously. So if someone gets these recurrent discogenic pains, it's not necessarily going to be with them forever. The bad news is once that thing scleroses, it'll probably translate to like facet-mediated pain. And, look at that. Facet-mediated pain. So honestly, if a board question comes up and says, hey, you have a 55-year-old male with axial low back pain and you have no other information, it's probably a facet, statistically speaking. Like I said, these are the bony attachments of the vertebral bodies. By far, the most common facets being affected being L4 or L4-5 and L5-S1. Typically, like osteoarthritis, can be secondary to degenerative disc disease. So what I tell patients, and I like to talk with my hands, but that's going to be hard with this. But that's okay. So degenerative disc disease, you lose some of that height, which means you get more like anterior, posterior movement, and then these facets are on the back, so that can lead to degeneration in the facets. Did that help or did that hurt? Did anyone hear me back there? Excellent. So the innervation of these and don't worry too much about the data on here. Most of this is just if you want to look at the slides later and you're really deep diving into it, it's all going to be there. But each of these joints has a innervation from above and below. So the superior articulating process and the inferior articulating process each have their own nerve supply. The reason that's important is the way that we treat it is going to be targeting those nerves. So stay tuned. Stay tuned. So what does this sound like? Axial pain. When I say axial pain, I mean pain arising in the spine itself, or at least a significant component of it. These can have a referred pain pattern, and you guessed it, right in the butt, down into the hamstring, usually above the knee, but guess what? It can go as far down as the calf. You may be able to poke on the facets, and the patient goes, ow, 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 that's my pain. And worse than extension, because that puts a little bit of pressure right there. So this distribution is the bane of most people's existence because guess what? That's also the referral pattern for SI joints. Discs can have that referral pattern. S1 right there. It could be a little bit of L5. So unfortunately, this back of the leg sciatica pain doesn't give you a lot of information, okay? And MRI findings, honestly, you could have the nastiest looking facet, not be their symptomatic one. So like if it says it on their MRI, lumbar facet arthropathy, great, but that doesn't necessarily mean that's where the pain's coming from. Now, how do we treat it? All right. So honestly, I should have flipped these. See, when I was in the military, I loved intra-articular injections because of our patient population. Turns out bouncing around in a Humvee with 40 pounds of gear strapped to you isn't great for your back. So you'd get early degeneration because typically you're not going to see this until about 45. But I would see people in their mid-30s with true reproducible facet-mediated pain. And an intra-articular injection was my go-to. So you would load them up with a little bit of steroid and local anesthetic and just guide it right into the facet. Drop a little of that in there. And I would like to see 6 months to 2 years, especially in these patients that it's more of an inflammatory process. Unfortunately, insurance, dictates what we're doing on the outside. And it's a little annoying because half the insurances don't approve it. And it's annoying when you have like a 30-something-year-old because guess what? I don't want to do this next one on them. So the medial nerve, medial branch of the dorsal ramus, you do a nerve block, and then you can follow it with a radiofrequency ablation. So those nerves we talked about going to the facets, you just go down there, drop a little numbing medicine on them. They get off the table and say, oh my gosh, this feels great. Well, guess what? It's going to go away in 5 to 6 hours. And then insurance makes us do it again. Don't get me on my soapbox with that. I think it's stupid. But then we can follow it with a radiofrequency ablation, take a specialized needle, active tip, zap the nerve, and try to get around a year of relief. They do grow back because we're just destroying the train tracks, not the train tunnel. And that sounds great, right? But there is one major downside is medial branches also innervate your multifidus. And so what's the first thing we tell people when they have low back pain? Strengthen that core, right? Particularly the posterior core. So this is that risk versus benefit. So if you have a 60-year-old that hasn't been able to participate in physical therapy, can't walk for an appreciable length of time and stuff like that, I zap the multifidus, but now they can participate in their physical therapy. So by the time all this stuff's wearing off, my goal with them is to be more functional than when we started, right? So that's that risk versus benefit. If it does come back and they're doing all the right things, this is a viable long-term treatment. And I call it, the patient's oil change. You just come in every year, we zap it, but, continue with your physical therapy because the main goal is functional improvement. All right, this one I feel like is my favorite. And I don't know this because I come from an osteopathic background, and when I was learning at LMU, we did a lot of sacral stuff in the OMT lab, but I feel like people forget about the SI joint. They'll try the medial branch blocks, they'll try the epidurals, and they'll be like, well, there's nothing else I can do for you, but yet it's like right there. You'd be surprised how many times people have been in the system for decades and no one's touched the SI joint. Very frustrating because the prevalence is pretty darn high. Now, this can happen anybody, any time of their life. So if you have like a 55-year-old male with axial low back pain, like I said, if that's the only information I know, it's probably the facets. But don't forget the SI joint. But this is also one that'll crop up in younger patients, particularly if you've had a lot of babies, because that relaxing, getting in there, moving things that ought not to necessarily be moved that much, and kind of then re-solidifying it. This does crop up. So what does it sound like? Very similar to the other one, except maybe your finger goes just a little bit lower, because the location of the SI joint in relation to your lower facets is not that far off. But if you say, where is your pain? and the patient goes right here, guess what? It might be the SI joint. Now that has a high sensitivity but a low specificity. So what I'm getting at is if they say my pain is right here, that's unlikely to be an SI joint, and the sensitivity is up in the 90s. So while it can technically happen that patients aren't like my pain's here, the SI joint tends to be irritated because what can happen, especially with like a facet, is the primary pain isn't necessarily here. It's this referred burning, tingling down into the like thigh, which you might be like, oh, is that radicular or facet? Whereas SI joints tend to always be tender at the SI joint. There are physical exam findings, and I'm sure Dr. Whiting's going to be sad about this, but I don't find them that useful. It's like 50% sensitivity, 50% specificity. Theoretically, if you add them together, like if you do 3 of them, it's more indicative of SI joints, but there was a recent study that kind of shed a little bit of doubt on that. And so it is an insurance requirement, so I document it. I'm just saying the gold standard for diagnosis is typically to put a needle wherever you think the problem is, drop local anesthetic, and guess what? If it gets better, I mean, there is always, false positives. It's probably coming from that area. So how do we treat it? This is actually one that has decent evidence for manipulation. So I still do OMT in my practice, but it is difficult because if I advertise myself as an OMT provider, then I would be doing only OMT. But for these patients that have these recurrent SI joint pains, these are ones I'll make an exception for, bring them in and see if I can get that working again. So this is in conjunction with physical therapy. And then the steroid injections, I find, and I don't know if it's just because insurance only covers them for every 3 months, but it's almost like 3 months to the day. It's really weird. And what I'll find is if someone gets like 1 or 2 weeks of improvement after an SI joint injection, they probably also have facet-mediated pain. Because if I just take a steroid and shove it into your glute muscle, it's going to make your low back feel better for about 1 to 2 weeks. So anyway, I'm getting off my getting off topic. So this is one we can do an SI joint RFA. This data is kind of from older methods. There's a bunch of different ways to skin that cat. There's no like one unified way to attack the nerves going to the SI joint, but RF is a possibility. A lot of insurances don't necessarily cover it. Surgery of the axial low back pains, SI joints tend to have the better evidence for surgery than other parts. So if it's just facets, your chances of getting better with surgery, really bad. SI joint, technically the data looks good, but guess who's putting out the data? Oh, that's right. The people making the devices to fuse these. And you're not going to believe this. There's a recent study that showed 98% of those studies are in the affirmative. Isn't that crazy? How did they do it? Anyway, so take it with a grain of salt is what I'm getting at. But looking between the lines, overall the data looks better. So once again, if you read your own MRIs and you see this, you're like, oh, maybe they just need physical therapy. No, I'm just kidding. They do need physical therapy. Don't get me wrong. But this is one that you're really going to want to correlate with their symptoms because this is what's called an extrusion. So if you see the term extrusion on your MRI, what that means is this base is narrower than the apice of the protrusion. So it goes protrusion to extrusion. And if you want to sound really smart, just try not to say disc bulge. I mean, there's technically something called a disc bulge on a radiologic finding, but it doesn't happen that often and it's not symptomatic. So if you want to sound really smart, you'd be like, oh yeah, we got a protrusion or an extrusion at L4. But anyway, you don't have to worry about that, but that's one of the pet peeves of like radiologists when they're chatting with you. So radicular pain can be independent of, let me word this correctly. You can have a radiculopathy without radicular pain. Okay, so a radicular pain is a type of radiculopathy. So when we think of radiculopathy, we usually think of, weakness, technically kind of peeing and pooping on yourself. That'd be more of a cauda equina, but kind of in the same realm. You're losing a function typically, and that's going to be the mark of an actual impingement, meaning I have structure against structure, and you usually get deficits with that rather than pure radicular pain. So what you're going to see mostly, like we chatted about a little bit ago, is you're going to have a disc pop, get hot, and that's going to irritate the nerve root that's running right beside it while not actually squishing it. So you're going to see these patients with pure radicular pain without weakness, okay? These patients are, they respond really well to pain medicine treatments. Technically, they respond really well to surgery, but they'll probably resolve in 6 weeks. So the decision of, risk versus benefit of do you just go in there and, pull the disc out or wait, we'll talk a little bit about that later. I just left this in here just because, everyone needs a refresher on dermatomes once in a while. This is where the epidural is king. So I know a lot of times we get, a bad taste in our mouth when we say epidural because you'll have patients that just go in, get them every 3 months, and we're like, they don't work and stuff like that. But for radicular pain, that's where they really kind of shine. Like I'm surprised if someone's radicular pain doesn't improve with an epidural steroid injection. And then, like I said, what I'll try to do in our practice, and of course, insurance in their infinite wisdom try to get in the way of this, but I'll bring a patient in after they get an acute radiculopathy. Most of the time it takes long enough to get in there that it's already resolved, right? So I try to get them in before it's resolved so we can zap it with the epidural so that, it's going to resolve itself in 6 weeks, but if you don't have to be 9, 10 out of 10 pain for 6 weeks or 4 weeks, by this point. Anyway, other things you can try tossing at it, gabapentinoids, SNRIs, TCAs. I think it's good to kind of get those started as soon as you see it because those are going to be targeting the neuropathic component of this pain. Opioids do not tend to do much for this. And it's hard because, you have the patient suffering in front of you and you're like, I want to help you. But the issue is on any dose that's going to be anything other than rendering them incoherent, you're not going to get much improvement in the radicular pain. Which is why I like the epidurals so much. It's like I can actually offer you something that's going to help because almost universally they'll be like, yeah, I tried the oxycodone 5s or the 10s and all it does is make me sleepy or nauseous or something like that. It doesn't really help. Spinal cord stimulation, this is also where it tends to shine. This is where the data has been good since the 1970s. Now, not for an acute radicular pain because obviously you don't want to put in like a permanent device for that, but let's say you had radicular pain, didn't resolve, got surgery, continued to have radicular pain. That patient does extraordinarily well with spinal cord stimulation, and the new changes that we talked about like since 2010, 2015 have only made that better. So you're looking at like 80-90% improvement in about 80-90% of patients, which in the pain world are ridiculous numbers. You know what I mean? Like you just don't get those. And then surgery. Surgery, this is one where I will have them chat with a surgeon, particularly if they have that big old goose egg coming out there and they're really miserable, because the procedure to do this is relatively minimally invasive and they can just go out and the patients typically don't even have post-op pain because the pain relief from the procedure is so great that they're just like, oh my gosh, this is awesome. But the issue with that is once you've taken something out, there's no putting it back in, right? So you tend to get, like if you go and take out the disc, then you get more of that translation, which might lead to spondylolisthesis, which may mean eventually they may need hardware, and then all the problems that go along with that, blah, 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 blah. So it's not something that you just want to throw at everyone willy-nilly is what I'm getting at. All right. Now we're experts on low back pain. Before I move on to the next part, do we want to take a few questions on low back pain? Yeah, because otherwise it'll be almost a completely different topic, you know? No? Excellent. Because you're all experts. Perfect. Excellent. All right. This is one that I promised a rheumatology preceptor that I would bring up anytime I had the ear of a bunch of people. Complex regional pain syndrome. So the reason I like to bring it up is you are going to encounter this at some point. Now, whether you recognize it or not, depends on how well you pay attention, probably. No, I'm just kidding. But this is one that all of the evidence shows treatment is most beneficial in the first 6 months of getting this. Average time to diagnosis, now this number comes from about 5 years ago, 6 years. Okay, so this is the patient that gets flopped around, you're just crazy, or I can't figure out what's going on, or it's not dermatomal, so I don't know if it's coming. This is that patient, okay? It's got a bunch of different names because you're not going to believe this. It's been around a while. So like even in the Civil War, they had that's where they kind of termed the causalgia one. So you'll see causalgia, reflex sympathetic dystrophy. Those honestly are the two most common ones. But if you run across any of these names, we're probably talking about the same thing. In the mid 1990s, the pain guideline people kind of said, you know what, let's just call it CRPS type 1 and type 2. So what is it? So this is chronic, it's complex, it's regionalized, and there's a pain component to it. So complex regional pain syndrome. That's right. Okay. Now, the pain is out of proportion to the inciting event. So typically you're going to have like the prototypical patient. Technically, it's more likely to happen in the upper extremities, but I swear I almost always saw it in the lower extremities, so whatever. But let's say you fracture a toe. You just get a stress fracture. You went running too much, you're in the military, you get a stress fracture in the toe. We expect it to heal up. You got 2 to 4 weeks per site, doing all the stuff. But all of a sudden, it starts getting red, swollen, angry, but not just where the bone is, kind of across the whole foot. And it becomes so tender, you're like, oh my gosh, does this person have gout? Because it's like they can't put bed sheets on it. It's allodynia. All right, we talked a little bit about all these points on here, so I'm just going to move on. Don't really worry too much about this. Type 1 and type 2. So technically, type 2 is a causalgia, so that's where we know that there was a nerve involved. It's not necessarily in the distribution of that nerve, but like let's say you have a humeral fracture, and then you got the radial nerve wrapping right around it, and so they get pain originally in the radial nerve distribution, and then it evolves, okay? And then type 1 is we don't have a specific nerve involved. And I think the big reason we're kind of moving away from this differentiation is, guess what? The treatment's exactly the same. So what happens? Typically, traumatic fracture, but you can get it from just like regular old sprains, and then you can get it from surgeries as well. Now, the surgeries that cause this are typically the ones that involve like manipulating bones. So orthopedic surgeries, particularly like wrist, ankle, stuff like that. Generally, a younger patient, female greater than male, usually only involving one limb, but You can have these kooky distributions where it'll involve other parts. Now, the thing is, we're talking about a disease that is kind of the, if no other disease fits the description, this is what we're going to call it. But yeah, if someone has starts developing bilateral neurologic symptoms and stuff like that, don't just be like, oh, it's just a rare form of CRPS. You know, like MS. I mean, well, there'll be a whole differential slide on here, but what I'm getting at is it can be weird, but most of the time it's going to be one. We talked a little bit about that allodynia, and once again, if you want to sound super smart, allodynia is pain from a stimulation that is not noxious, like the bed sheets. Hyperalgesia is excessive pain with a noxious stimulus. So you pinch someone and they jump out of their seat. Well, I mean, I guess if you did it when they're surprising them. You go to put local numbing medicine and they're like, ah, right? That's not really a normal reaction. So that would be hyperalgesia. And we'll talk a little bit more about these vasomotor changes in just a second. Now, these happen in stages. So you got 6 months to each stage. So it usually starts as that pain, sensitivity, and localized edema, and then it goes on to changes. This is where in stage 2, you're going to have some changes that you can actually find on MRI. So if you MRI it and it's got these weird bony lesions, and hopefully the radiologist says, you know what, indicative of CRPS. It's probably in this dystrophic stage. Nails can pit, hair kind of falls out, and then it starts getting restricted at this point. As you can imagine, it's really useful to get physical therapy involved well before this has happened, because then you go to the atrophic stage where you have severe restriction of movement and anatomic dysfunction. This is called Budapest criteria. I had a way of remembering it, but I don't know if it's politically. No, I'm just kidding. It's not that bad. So if you just think of Buddha sitting there, meditating, and a bug, or a mosquito lands on his leg, he smacks around it because he's not going to hit the bug, because he's Buddha, right? But then his leg gets nice and red and swollen. That's how you can remember Budapest, because of the bug criteria. You're welcome. You'll probably never use it again, but. So this is, like I said, vast differential diagnosis. So just because you think it's CRPS doesn't mean it is. It can be several different things. But like I said, each of them has a little nuanced difference that doesn't quite meet with CRPS. So diabetic is typically going to be bilateral, right? I mean, you're unlikely to get a unilateral diabetic neuropathy, but you could get some other, well, honestly, most small fiber neuropathies are going to be symmetric. You get entrapments and blah, 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 blah. I don't feel like I need to beat any of these up. Now, here's the kicker. Treatment. Once again, super important to get this started early, but talk specifically to the physical therapist and say, I want desensitization therapy. So that's where you can take them and essentially go from really soft silk, and then they move them up to terry towels, and then something a little bit rougher. This is kind of reprogramming the central nervous system to say, look, we're not hurting anything. This is going great. You'll be fine, right? Drugs, unfortunately, don't help that much. I mean, you can try, and particularly on the opioid side, it just, the doses you have to get to are ridiculous to even touch these things, and then it's with all of the problems associated with that. So I would highly, if you're thinking of going the opioid route, I would not start it. I would probably refer to a pain specialist at that time. Interventions. Now, kind of take out that lumbar part, because, I mean, you can do a lumbar, but sympathetic blocks. One of the hallmarks of this type of pain is your sympathetics, your fight or flights, are intimately related to your perception of pain. How that happens is still a little bit mysterious, but we know that sympathetics influence pain, and this is an example of where that goes nuts. So I have this theory, and this is just Dr. Shaver's theory of CRPS, is you get an injury. When you get the injury, your body sends out a sympathetic response to that area, right? It's like, whoa, we need to fight or flight, right? Get out of there. But when you send a sympathetic response to the periphery, you get vasoconstriction. What do nerves love more than anything in the world? Oxygen, right? So you vasoconstrict, nerves get irritated. Nerve sends back a signal, hey, we still have more damage down here. What's going on? So the body's like, well, let me send more sympathetic input, right? And then you set up this cycle, and then it gets out of whack. That's my theory as to how this is happening. So we can do a sympathetic block at several different locations. The lumbar, like for lower extremity, it's called a lumbar sympathetic block. You essentially drop it on the sympathetic chain, as you know, it terminates in the thoracic spine, but you have a chain of sympathetics going along kind of the anterior part of the vertebral body. And that's where we drop this medicine. And these patients usually love us because, once again, time to diagnosis is around 6 years. So they're like, I've been in 9 out of 10 pain for 6 years and nothing has improved it. These are the patients that start crying because they go from 8 to 0 on the table, which is awesome. Now, the effect is variable in how long it lasts. I find that if they've had it for a long time, it lasts about a week. If they haven't had it a long time, then you get maybe a couple months out of it. But during that time, you maximize the physical therapy. You're showing the central nervous system, hey, look, it's all right. You'll be fine. You'll be fine. And so the combo of the sympathetic block with the physical therapy is really where the magic happens. Spinal cord stim, historically, and this is going to be, long story short, there's 2 main types of spinal cord stim. One that actually stimulates on the spinal cord itself, on the dorsal column, and then one that directly stimulates the dorsal root ganglion. It's almost more of a peripheral nerve stimulator, but they're not called that. But anyway, the dorsal root ganglion stimulators have excellent data for CRPS, like getting into that like 80-90%, almost to the point that you can forego a trial and go straight. I mean, at some point, that's obvious, that's dictated by insurance, so they're not going to listen to medical reason. But yeah, now the issue is it's only been around since 2016 and kind of in this first generation. And even in the best hands, you've got a 15 to 30% fracture rate of the lead, which means it's like, oh my gosh, this is great. And then you twist the wrong way and it's like, oh, and it's back. But there are other promising interventions. Temporary peripheral nerve stimulators are showing some promise for this treatment because, similar to the idea of the sympathetic nerve block, if you can break the pain cycle, you have an opportunity for the pain to actually resolve. So even in those patients that have the fractured leads, if they'd had it running for about 3 months, we found they're like, yeah, the device isn't working, but my pain's gone. Great, excellent, wonderful. Which is why I still consider it an option, but they are a pain in the butt to put it out. If you want to ask about that later, we can talk about that offline. Honestly, I've never seen one of these surgical sympathectomies, but it's technically possible. Now, this is just miscellaneous things. These are things that if someone walked in while I was doing primary care and said, I have these things, my brain just wouldn't send to pain medicine, right? Peripheral neuropathy, particularly diabetic peripheral neuropathy. It just got FDA approval in the last 6 months, but you can do spinal cord stim for diabetic peripheral neuropathy. And once again, all the numbers are coming from the salesman. I get it. But looking between the data, it looks fantastic. And 80, 90% improvement, 89% of patients. And I'll say, and this has not been an investigated claim. This is just something that they noticed during their studies, but actually increased proprioception, both immediately and delayed. So there's a lot of interesting thoughts on that. One, signal to noise ratio, how much is a diabetic's proprioception put off by just the constant input from the nerves? And then 2, whenever you treat something with the dorsal column stimulator, spinal cord stim, you actually increase blood flow to the area that you're treating. So you have increased blood flow. They're looking at like calf biopsies for nerve fiber density and all that. So I think it's pretty exciting. Now, the thing is, most patients that get diabetic neuropathy don't stay in the persistent, painful diabetic neuropathy stage, right? I mean, it's like 1 to 2 years. So either you're gonna get it, and then you're gonna go past that to the numb stage, or usually the patient is like those ones, their A1C's floating in 12, and then they're like, they don't care until their foot starts hurting, and then they say, oh man, I'm gonna do something about this. They drop it down to 7, but they kind of stuck themselves at the spot where they're painful, but they're not continuing to destroy the nerves, so it stabilizes. That's the perfect patient for this system. Testicular pain and dorsal root ganglion stimulation, oh my gosh, they're slam dunks. Like it was awesome. Like in the military, you'd have these folks that came in, they tried like the nerve stripping, urology will do that, and all this other type of stuff, persistent testicular pain. We had some people that, it almost drove them batty, right? And then you pop that one lead in there, and it just. Now, I will say, I'm getting you all excited about dorsal root ganglion stimulation. It's hard to find someone to actually implant these. I've done them before, but once again, we can talk offline about the intricacies of why it's a problem, but promising. So just as you see these patients, know that they may benefit from a referral that you wouldn't have thought otherwise to give. Does that make sense? All right, so that was the bulk of the talk. This was just more of a, if you guys are interested in it, or if you just want to go get coffee and brownies right now, either or, I'm happy to do either. We'll take some questions on the first part of it, and then we'll kind of decide how much time we have. You want to borrow this one?
I can shout.
Yeah.
If you were to catch the CRPS in the acute phase, say a couple of weeks of moderate inflammation in an extremity, moderate pain, in a patient that wanted to avoid opioids or the pain medications that were mentioned, how would you approach that?
Excellent question, because these are the patients that, statistically speaking, are most likely to be influenced by early intervention. Now, I failed to mention earlier, 90% of CRPS will resolve itself within 6 to 9 months by itself. But how do we predict which one of those lucky 1 in 10 are going to be the chronic ones? So I would err on the side of doing starting the physical therapy, like a specific desensitization physical therapy, let it run for just a little bit, and then I would probably follow it up with a lumbar sympathetic block. The risk versus benefit, I think, is in favor of just getting in there, blocking it, and seeing if we can get them a time that physical therapy can work on it, and then probably running that for maybe 3 to 5 cycles. But as I mentioned earlier, these patients, when they get in early, I tend to see several months of improvement on the lumbar sympathetic side, and statistically speaking, if they're going to get better anyway in 6 to 9 months, it may be a one and done. So, yeah.
Any other questions for Dr. Shulver?
Nope.
We have
Excellent.
about 6 minutes until the next lecture starts.
Yeah, I'm not going to inundate you with this stuff. You can just look on the slides, and I have a pretty good handouts to help with like non-opioid adjunct therapy. Just kind of like a little refresher. Oh, I will say though, this was something I learned when I got into fellowship, and I was like, oh my gosh, that's brilliant. Gabapentin. No one teaches you how to dose it. You're just like expected to know it from birth, right? So long story short, try starting your gabapentin all at night. Most of the negative symptoms are sedation, right? So what I do is you can use that. So gabapentin actually improves your sleep architecture, like your ratio of deep to superficial sleep. And so if you have someone that's even a little bit insomnic and has chronic pain, that's what I would do first. Just hit them with like 300 at night. And like I said, most of the symptoms are going to be while they're sleeping. Ramp that up 300, 600, 900, up to 1200, usually somewhere between there. They're feeling good, but and then they want to add some daytime doses. Great. Let's try 300, 300, 300, 900. That way their body's used to that 900 dose, so the 300 doses don't tend to zonk them, right? Anyway, that is one piece of advice that I found to be super useful.
Dr. Lee Cottrell attained his doctorate in audiology from the University of Tennessee in 2011. He has been a fellow in the American Academy of Audiology since 2017. Dr. Cottrell serves as a committee chair for the American Academy of Audiology Federal and State Relations Committee. He has previously served as adjunct faculty with LMU-DCOM. As a clinical audiologist, Dr. Cottrell provides comprehensive audiologic services for adult and pediatric patients, including diagnostic testing, amplification, and vestibular testing for balance disorders. As audiology director at Farragut ENT, he oversees a team of 7 audiologists working alongside ENT specialists and physical therapy. Please help me welcome Dr. Cottrell.
Thank you. Thank you. I believe I'm second to last in the program, so I see the clock too. We'll move quickly through this. First of all, I do have relevant financial disclosures. You cannot trust me. I am tainted. However, I am not primarily a businessman. I'm not primarily, not at all, a researcher. I'm a clinician. So my full-time job, my day job, I'm an audiologist working with ENT physicians, and I work very closely with a group of primary care physicians as well. Today we're going to speak very briefly about hearing loss and dementia. So here in one sentence is the whole talk. Hearing loss increases the risk of dementia. The use of hearing aids or cochlear implants decreases the risk of dementia. So that's it. But we're going to examine at least a little bit of detail. A brief review, back to whatever day that was in med school. The human auditory system is made up of the ear and the brain. We hear with our ears, or more accurately, we hear with our brain, but it's the ear that takes sound to the brain. And the ear is made up of 3 parts, outer, middle, and inner. There are both passive and active mechanisms of hearing in the ear. A passive mechanism would be this floppy thing out here, the pinna, or the auricle. It is shaped in such a way as to conduct sound and actually amplify the speech sounds that are most critical for at least most languages understanding conversation. So somewhere between 1 to 3,000 hertz, this device on the side of the ear amplifies maximally. There are also active structures in the inner ear and the cochlea. There are tens of thousands of little bitty tiny hair cells, and those hair cells are actually moving dynamic structures, which is relevant to what we'll talk about in a moment. Let's see, that's this one. Hearing loss, we classify into 3 different classifications: conductive, sensorineural, or mixed. Conductive hearing loss occurs when there's damage to any of the outer or middle ear structures. We might call it structural hearing loss, or physical damage to the mechanical structures of the ear: outer ear, middle ear, eardrum, the ossicular chain behind the eardrum. Usually, conductive hearing loss is treatable, meaning it can be repaired. So wax in the ear can be cleaned out. A hole in the eardrum can be repaired. Often heals spontaneously, but if it doesn't, it can be repaired, usually. Damage to the bones behind the eardrum can be repaired, usually. Sensorineural hearing loss, this is the classification for most hearing loss, or at least most hearing loss that's age-related or related to noise exposure, chemical exposures, chronic inner ear disorders. And sensorineural hearing loss is damage to either the auditory nerve or the sensory receptors in the cochlea. 75 years ago, everything in sensorineural hearing loss would have been classified as nerve deafness or nerve hearing loss. And it's really more accurate to separate sensory and neural, because while the auditory nerve certainly can sustain damage, and that's a really big problem for hearing, much more common in age-related or noise-related hearing loss is damage to those cochlear hair cells, those little active dynamic hair cells. when they take a beating from extensive or extreme noise, or just use over time, they're going to either die off or sustain damage, and now the auditory system is not going to be as finely tuned, and those patients are going to complain of hearing problems. But sensory neural comprises both nerve damage, like an auditory nerve tumor, and age-related hearing loss, cochlear hearing loss. The cochlea, the snail-shaped, coil-shaped organ of hearing, is arranged tonotopically. If you were to uncoil the cochlea, it would play out like a piano. On the one side is where we code very low-frequency sounds. On the other side is where we code very high-frequency sounds, and everything in between. And the way it's constructed, the inside of that coil, the middle of the coil, is where we code low-frequency sounds. Consequently, it's very, very well protected against noise exposure. The fluid waves, the pressure waves that travel through the cochlea and displace those hair cells rarely get to the inside of that coil, the apex of the cochlea, with nearly the force that they hit the outside. Because of that, when people lose hearing gradually from noise exposure or just gradual hearing loss due to aging, it affects the high frequencies. That's a little too much. From the cochlea, the cochlear hair cells, there's a chemical reaction that triggers the nerve to fire, and the auditory nerve is a bundle of nerves, and those nerves all fire, and there's multiple different little way stations on the way from the ear to the brain, where on the right side of the brain, speech is processed. We don't really have time to get into all of that right now, but let's move on. When a person experiences hearing loss, they're going to experience the loss of audibility. That means they can't hear. But very few people come in and say, hey, yesterday I could hear and today I can't hear. Hearing loss occurs much more gradually, and usually the problem is a significant problem before it's an extreme problem. So loss of audibility isn't, at least for us, the first complaint that we see. Hearing loss certainly does impair audibility, but it also impairs temporal resolution, meaning they can't process speech on time. They can't process speech quickly. A lot of times people complain, well, I can hear just fine if you speak a little slower. Similarly, hearing loss allows for spectral smearing, so impaired spectral resolution, meaning they can't distinguish pitches as easily as they could. So these things occur gradually, and it's not a sudden loss of all hearing abilities. It's a gradual loss, and a gradual loss of hearing clarity. That leads to frustration, increased effort of listening, can lead to social isolation, decline in overall quality of life. And that last one I think is always interesting, reduced performance and earnings in the workplace. There's a Better Hearing Institute study from 2005 that, as far as I know, hasn't been replicated. Nobody's bothered with it, but it showed that in 2005, people with hearing loss in the workforce, when normed against their normal hearing peers, earned on average $12,000 a year less for similar positions. And that may be because they can't perform, that may be because they can't advance, not quite sure. But hearing loss has a number of different effects. I'm going to move on to the effects that we're going to talk the most about are the effects of hearing loss on other conditions. Specifically, an increased risk of dementia, of cognitive change over time. This has been something that's been studied extensively, but only recently. Hearing loss increases the risk of falls and injuries related to falls, and it makes sense because the inner ear is where we have our equilibrium system, our vestibular system, and it's also where we have our hearing system. And there are conditions that can cause damage to both functions, but it seems that even independent of vestibular disorder, that people with hearing loss are more likely to fall, which actually probably relates to our discussion of hearing loss and cognition. There's also an increased risk of depression with hearing problems. So why is there an association between hearing loss and cognitive decline? Well, I'll go ahead and talk for a minute on this slide. I won't advance for a few minutes. The truth is we don't know. We know some things, but we lack knowledge in some things too. There's a concept called auditory deprivation. So if the brain is deprived of auditory stimulation, the brain is understimulated, then we know a brain with hearing loss is deprived of auditory stimulation. We know that people with hearing loss, their brains shrink faster than people who maintain good hearing. So auditory deprivation is probably part of the story. Reduced environmental awareness. So if, especially with a severe hearing loss, if you're less aware of your environment, you are more likely to miss safety cues, more likely to fall. You are more likely to miss social or conversational cues, more likely to miss things. There's also a reduced or distorted input to the brain, goes along with auditory deprivation. And then there's this idea of cognitive load, that the brain's only got so much power. And if you have to use extra brain power for the listening task, you have less brain power left over for short-term memory storage, generating appropriate responses in conversation. And that idea of effort is listening for a person with hearing loss is a stress. Well, what do most of us do when we have known stressors? We avoid. So people with increased hearing problems are much more likely to avoid those hearing situations which cause them stress. So I don't need to tell this room that dementia is a big deal and your patients don't want it. The healthcare expenditures, we looked this up about 6 or 7 years ago, and at that time the best figures we could come up with were public health expenditures for dementia care are like $50 billion a year. You know, it's an expensive deal, and it's a huge quality of life problem. Hearing loss is independently associated with accelerated cognitive decline, and the risk of cognitive change in the hearing loss population increases with the severity of the hearing loss. So a severe hearing impairment quintuples the risk of cognitive decline. The Lancet a couple years ago put out just this great big giant study and their kind of position statements on a number of different things. And you can't really see that graph too terribly well, but you see there's a blue cluster and a purple cluster. The blue cluster is midlife, the purple cluster is later in life. Hearing loss, of all the things they identified, hearing loss, traumatic brain injury, hypertension, smoking, depression, social isolation, physical activity, educational attainment, hearing loss was the factor most highly correlated with dementia among all of the what they call potentially modifiable risk factors. You can't pick your genetics. But you can potentially modify your risk for or your treatment of all of these other things. So hearing loss accounted for what they said 8% of the potentially modifiable risk factors, and their kind of take-home message for all of these things, the percentage reduction in dementia prevalence, if you could eliminate that risk factor, and for hearing loss was 8%. So what can we do about it? Hearing aids and cochlear implants are the most common interventions for hearing loss. Hearing aids, reference back that slide a few slides backwards. So what are the consequences of hearing loss? Well, speech understanding, quality of life, ease of listening, auditory stimulation. This is that same slide in reverse. Hearing aids and cochlear implants or osseointegrated implants should improve quality of life, improve speech understanding, improve ease of listening, auditory stimulation, and decrease the risk of dementia. Now, when we started partnering with LMU in our practice 6 or 7 years ago, I don't remember exactly, I had that little bullet point with an asterisk because at that point, all of the publications on the topic said this is possibly true or likely true, but we don't really know yet. Well, over the past 3 years, there have been a number of studies who have published on this topic, and all studies disagree on the impact they have, the effect size that hearing loss treatment has. But all studies agree that hearing loss treatment, hearing aids and cochlear implants, does in fact decrease the risk of dementia. Hearing aids reduce the risk. Again, depending on which study you read, the risk appears the same as people who have normal hearing. Hearing aids are safe, effective, and cost efficient. Over-the-counter hearing aids are now available. On that bullet point number 2, hearing aids are safe, effective, and cost efficient. So safe, yeah, hearing aids can't hurt anybody. They're effective. That's what the previous slide just said. And hearing aids properly employed really do help people. Cost efficient. Now here we hit a little bit of a snag, a little bit of a roadblock, because one of the biggest criticisms of the hearing aid industry over the past 60 years is that hearing aids are so stinking expensive. And that remains true in many places. Well, that remains true everywhere. However, hearing aids are increasingly getting insurance coverage. Medicare Advantage plans, about 85% of them cover hearing aids. Traditional Medicare still does not, so Medicare beneficiaries do not have hearing aids available at a reduced cost. But commercial insurances and Medicaid plans, depending on the state, depending on the age of the patient, is way more common than it used to be. And now, this is just an anecdote, but I started 12 years ago, and about 5% of our hearing aid patients were reimbursed third party. Fast forward now, is about 75%. So it's something that is going to be increasingly a covered expense. However, that is still a stumbling block for many people who are older, on a fixed income, know they have a problem, but I don't really have $2,000 to go out and get hearing aids. So I picked cost efficient as a word. The argument that's going to have to be made to Medicare and other payers is the argument that, depending on the patient, we may have to make also, that a couple $1,000s for hearing aids now is a worthwhile investment to defray the risks of not getting hearing aids, both the social communicative risks and the overall health risks. So who has hearing loss? Everybody. So close to 50 million Americans have measurable hearing loss. It is more common in men. It is more common in whites than blacks or Hispanics. Among men, ages 50 to 59, about 20% of men will have a clinically significant hearing problem. 26% of adults in their 60s, 55% of adults in their 70s, and 80% of adults over 80. And then you look at that and you think, hang on, are 20% of my 80-year-olds actually normal hearing? Probably not. It's probably underreported. So this is self-reported data. So in audiology, hearing loss is what we do all the time. In ENT, hearing loss is what we do all the time. In primary care, you'll see and treat everything. So what should primary care be on the lookout for? Well, the primary care doctors that we work closely with, we suggest questions at intake. Make your patients do the work for you. We recommend a full hearing evaluation at age 50. So any patient that comes into our ENT clinic, if they're 50 or older, we're saying, hey, have you had a hearing test? Why don't we go ahead and get a hearing test? Well, I'm here for my sinuses. Well, we don't have to do it today, but we recommend if you're age 50, you've never had a hearing test, let's get a baseline test. The U.S. Preventative Services Task Force has looked at this a couple of times. So far, they've disagreed with us. So that's what I say. It's not what they say. But a hearing test doesn't hurt. A hearing test is a piece of cake. It takes 10 minutes and costs the insurance company $30. You know, a hearing test is an easy thing to get, and a baseline sure is nice to see. And to be quite frank, a lot of people who have mild or moderate hearing loss don't want to admit it. So the people who come in and say, man, I really can't hear anything, they've probably had gradual progressive hearing loss for years. The average is 7 years from the time when the patient notices a problem to the time when they do something about it. So 7 years on average. standardized questionnaire or screening for Medicare. So Medicare requires annual wellness visits, and as part of the annual wellness visit, there's a hearing screening component. It's up to the provider to figure out how you want to do that. Most providers I've worked with are either using a standardized questionnaire, a finger rub, or a whisper test. When you look at CMS's papers and their guidelines on this, and actually there's, I think my last slide will have a link. The AAFP has a position paper on hearing loss, and they've got a nice table of all the different screening mechanisms and whether they consider it, we give this grade A, grade B, grade C, what's the efficacy of these things. The whisper test is the best screening for hearing loss, if you do it right. There is a standard recommendation for how to perform the whisper test. We've observed there's a lot of people who have to do wellness visits all day, and they try to do those whisper tests so that everybody passes. If you stand in front of somebody and say, "What's your favorite color?" they're going to whisper back, "Red." They can all hear you because they can see you. If you do the whisper test correctly, you're doing it behind a patient, you're giving them a list of numbers or words for them to repeat. It's a little bit more than just asking them what's their favorite color face to face. But the whisper test, as recommended, isn't a 10-minute test. It's like a 10-second test. So the whisper test is the best screening that's out there. There are diagnostic screening tools that are available in the primary care or general practice clinic setting. A lot of pediatricians use them. Increasingly, internists and geriatricians are using them as well. Over the past 20 years, there have been nice advances in audiologic diagnostic technology. You don't have to have an audiologist on staff to get diagnostic information. You can get automated testing done really pretty quickly and efficiently. And then, of course, referrals to audiology and or ENT. So the challenge is that hearing loss is a quiet condition that occurs gradually. Individuals with hearing loss often deny or minimize the condition. Hearing aids or cochlear implants, those are a solution that nobody wants for a problem that nobody wants to admit. But we do have the opportunity to significantly improve patient lives, quality of life, overall health through collaboration between the medical community, audiology, and educating our patients. Look at that, early. Am I doing questions now, or are we doing that at the? We're waiting until the end. Okay, that's it. Thank you for your attention.
Dr. Brendan Williams is a nocturnist at Baptist Memorial Healthcare DeSoto in South Haven, Mississippi, in the Memphis metropolitan area. He received a Bachelor of Science in Biochemistry from the University of Tennessee, Knoxville, and graduated from LMU-DCOM in 2015. Dr. Williams completed residency in internal medicine at the University of Florida Shands Hospital in Gainesville, Florida, and was appointed as an assistant professor of medicine at the University of Florida. He holds board certifications in internal medicine as well as obesity medicine. Please help me welcome my fellow classmate, Dr. Williams.
Thank you, thank you, thank you. It's wonderful to be here, see so many faces without masks. It's fantastic. So the title of my talk is After the Storm, because I don't know about you all, but in our community, COVID seems to have gone kind of by the wayside. We had a whole 12 hours in our hospital last week with no COVID patients. And then we were back to 1 or 2 single digits where we've been for a while, so it's fantastic. So what I kind of wanted to talk about was now the post-acute COVID, or what some people call long COVID, which I think might be a misnomer. First of all, I have no disclosures. I only get paid by my primary location where I work. So my objectives, identify the symptoms of post-acute COVID, or like I said, long COVID. Evaluate when you need to refer a patient to a specialist, because sometimes there might be more than we can handle as primary care. And lastly, I wanted to touch on kind of a transitions of care, because I think COVID exposed something that we all knew was not doing well, and that was patients who leave the hospital when they go back to their primary care. That transition is difficult. It's not gotten any easier. And I think hopefully in the future there are now things we can do and the patient can do to make that a little bit easier. So, terminology-wise, post-acute COVID-19, or abbreviation PASC, some people also call long COVID, long haul COVID, refers to just a range of symptoms. So, as we know, COVID was a multi-organ system disease that affected multiple things. Patients presented with multiple complaints occasionally. The most common one we know of was shortness of breath, needing oxygen, having to stay in the hospital, mostly for oxygen. One we saw, especially early on, was actually syncope. We had a lot of elderly folks come in and they had fallen, no idea why they fell, probably because they were hypoxic and they had COVID. Sometimes these symptoms persist though. Let's say even 16 to 20 weeks after their initial COVID diagnosis, they're still symptomatic. They're still coughing. Say they're not on oxygen anymore, but they're still fatigued. They're not steady on their feet. So all of these kind of multi-system symptoms are still considered post-acute COVID-19. So this graph, this was a great reference I have. This is from Nature Medicine. I think it was 2021. Kind of encompasses the multi-organ symptoms you have with acute COVID as well as post-COVID. So it kind of gives you the time frame there, week 1 to 2, you test positive. Some people needed a hospital. Some people did not. They stayed at home. And they had symptoms ranging from neurologic, cognitive, shortness of breath, palpitations, abdominal pain, GI symptoms. So all multi-organ. And then as you move away from that acute phase, after the first 4 weeks, you get into this post-acute COVID, which seems to also be multi-organ. And then I've kind of broken this talk into the 3 most common, or the 3 maybe heavy hitters, we would call them, that we're focused on at our most recent American College of Physicians conference in 2022. And that's kind of pulmonary, cardiac, and then neurocognitive or neurologic. First, I want to touch on, there is a difference between post-acute COVID and then patients who were in the hospital and have, let's say, post-intensive care syndrome, which is a totally separate thing. Those patients who were so severe, they were in the intensive care unit for weeks to months, they're going to have a lot more complications that aren't really classified as post-acute COVID, but those are post-ICU care syndrome, which is its own thing, and it's pretty well studied and being more studied now. We have patients who were just in the hospital, and as you all know, the hospital's not the safest place. There's complications that tend to always occur. It's not a benign thing to be admitted to a hospital, as I'm sure many of us know. And then some of these overlap also with post-acute COVID. So this graph is where I wanted to get to that kind of overlaps. So this one, what I'm trying to get at here is that some people associate, well, maybe if you had very severe COVID, you're high risk of having post-acute COVID. That actually turns out to be not the case. The symptoms you get after COVID with what people call long haul, they don't tend to be congruent with your initial presentation. So like I said, if you take out those patients who have post-intensive care syndrome, which is separate, and you take out people who had hospital complications, it actually turns out those who are symptomatic, it doesn't matter how severe their initial infection was. They can still have symptoms that are persistent for weeks to months after their COVID diagnosis. So this is kind of a hard to decipher graph, but the blue is all of the acute symptoms that they had. So you can see there, yeah, severe illness, they were much more likely to have multiple acute symptoms. The smaller graphs, the kind of brown to yellow color, are people who are now at follow-up. The mild disease is the darker. So you see a number of these symptoms there. The people who had mild illness, as in they didn't need a hospital, they didn't need oxygen, maybe they didn't even know they had COVID until they got a test later on, they still tend to have these persistent symptoms week to months after. So it doesn't seem to matter how severe your initial diagnosis was. So that goes into this next slide. Who develops lung disease post-acute COVID? So those with pre-existing lung disease, people with severe COPD or ILD before they had COVID, are much higher risk to have persistent pulmonary symptoms after they were infected. People who did have a severe case of COVID, let's say they had ARDS, were on a ventilator, prone for weeks, they are likely to have pulmonary symptoms weeks to months after. But the last point here is what I was saying in the last slide. It may be somebody who didn't know they had COVID. They could still have that cough for weeks to months. And working up the lung-associated symptoms. So there's kind of a stepwise fashion. So somebody who has persistent shortness of breath and cough, say they're not to the point of needing oxygen, but they're still just coughing months after. Kind of want to start with a few things. So 6-minute walk test is kind of the standard of just how much can they exercise? What's their capacity? So it'd be great if you had a baseline. Most of these patients, I realize you might not have a previous 6-minute walk because they didn't have symptoms last year or year before. But the goal there's a chart that has kind of age-related goals, but in general, at least 1,500 feet in 6 minutes for the average patient would be reasonable. So you get that, see if it's normal. Next step, for, say, the primary care to do, you could get a high-res CT, which might not be the easiest thing with insurance, but if you have those persistent symptoms to back it up, hopefully will be possible. And then a set of pulmonary function test. If they have a baseline, again, great. If not, this will be their baseline at this point. And what you're looking for there are patients who might have developed post-fibrotic changes after COVID. Maybe they had ILD before and didn't know it because they didn't have symptoms. Maybe they had COPD before and they didn't realize it. And then they got a COVID infection that kind of unveiled things they already had that they didn't know about. Assuming all those are normal, you keep moving on. So the next thing that at least the chest article I read recommended was a VQ scan. And so there you're actually looking for chronic thromboembolic pulmonary hypertension, which has its own set of treatments now, apparently. And this is kind of the point where if you skip those first 3 tests, so you get those, everything looks fine, maybe consider getting a pulmonologist involved. Because at this point, you might be a little in over your head. I would be in over my head. I would say, I'm not exactly sure what's going on. So far, everything looks okay. Let's move on down the list. So get a VQ scan looking for CTEPH, and then kind of a cardiac workup. Maybe their shortness of breath or even their cough isn't due to their lungs. Maybe it's their heart. Maybe they have a little heart failure, valvular disease they didn't know about, or even an arrhythmia that's kind of gone unnoticed. The next slide, this is again from chest. This is prior to lung transplant, so it's kind of definitely specialized toward a pulmonologist, kind of be more of their wheelhouse, especially as you get near the bottom of the list. You get into these trial of steroids, antifibrotic treatments. Those would be for a pulmonologist to kind of determine for sure. So getting on down that list, the trial of steroids, this is from the literature, but we did have a patient, I want to say it was February of this year, who had COVID about a year prior, still just short of breath for a while, coughing, didn't know what was going on, not on oxygen, but they couldn't get up a flight of stairs without having to stop and rest. So we got a high-res CT, and theirs looked similar to this top one, B. So black and white picture CT, I don't know what that is. Is that pulmonary edema? Who knows? It's just black and white at this point. It doesn't look like it. It's not dependent, you would say. There's no interceptal thickening for you think this is all just fluid in the lungs. So part D is actually after the trial of steroids that our pulmonologist had done in the hospital. This isn't our patient. This is from the literature, but it's very similar to what we saw this in February. So trial of steroids, turns out they actually did have an organizing pneumonia. There specifically was a hypersensitivity pneumonitis, so it responded very well to steroids. But still, they think it was associated with their previous COVID infection, and it might have just been unmasked by their symptoms not responding or getting better. So kind of the next big system is the cardiovascular system, and a lot of people are still talking about that. You get that workup, you get the echo, say it's normal, you might want to send to a cardiologist. There are other modalities of diagnostics that they would get, including a cardiac MR, looking for other types of pathology. A 6-minute walk test would also be part of this. The easy thing about the cardiac symptoms, and some of this talk is kind of anticlimactic, because unfortunately the answer to a lot of it is, well, you just figure out what their symptoms are and you treat those. Unfortunately. I know none of us like to hear that, because I feel like we're stereotyped by doing that a lot, but we usually don't. But with post-acute COVID, it seems that's kind of a theme. What are your symptoms? Are you coughing a lot? Let's give you some cough medicine, that kind of thing. But cardiac is very specifically that way, kind of as an overall arching theme. This slide's a little scientific, but one of the things I wanted to get to is, aside from the lungs, COVID-19 wasn't really found in a lot of organs at autopsy. I don't know if because it's difficult to find, but at autopsy it wasn't really found in neurons or in the brain. It's not really been found in in the heart muscle as much. So it's more of an endothelial disease. So it really affects the endothelial, makes it leak. This slide's very busy, but some of this kind of goes on toward the post-acute side too, because this healing process might take a little bit longer than we initially thought. So patients are still at risk for thromboembolism after they've had COVID. And a lot of these kind of inflammatory disorders that come along with it can last a lot longer than we initially thought. So as I was saying a little previously with the cardiac symptoms, there's a lot of things that can happen, and maybe they're unmasked by COVID, maybe they're caused by this endothelial dysfunction that COVID seems to cause, but you just manage them how you would manage them if COVID wasn't involved. So they have an arrhythmia, you treat them, you rate control them. If they have a high CHA2DS2-VASc score, you would anticoagulate them. If it's, say it's AFib. Ischemic heart disease, you would treat just like any other ischemic heart disease, aspirin, beta blocker, statin. Heart failure, exact same management. Go all the way down the list, and everything is pretty much the same as you would manage it with or without COVID. So the cardiac recommendations that came out with ACC, it's a very long list, and I didn't get into return to sports because that's definitely not my wheelhouse, but their recommendations are to treat each thing as you would with or without COVID. So the neurocognitive part, this kind of ties into the hearing loss. COVID not classically causing hearing loss, but patients who get COVID come back in the hospital weeks later and they're still not back to their baseline. Maybe they're a little more forgetful. Maybe they're still altered. Maybe they didn't actually go home after they left the hospital. Maybe they went to a nursing facility and they've still just been not quite recovering back to their cognitive baseline as before. So that's something we've definitely seen a lot of in COVID. And again, treatment of all these is just the symptoms. You keep going forward with that. So more to the treatment. This is William Osler, a Canadian physician, kind of one of our fathers of internal medicine, as we say. He says, the good physician treats the disease, the great physician treats the patient who has the disease. So validation of their experience. I'm sure you all see this a lot, but as soon as you say to the patient, I understand what you're going through, and I'm very sorry, to them that means a lot. So just don't minimize what they're telling you. If they're telling you, I just don't feel right, I haven't felt right, say, well, this is a known disease process. It can kind of ravage the body just as we've expected with acute COVID, might not get better. That validation can mean a lot. As I said before, symptom management, unfortunately, is kind of the mainstay of post-acute COVID therapy. The biopsychosocial model, I know I was talking to a couple different people in the audience about this. This is what they use every day. Everything's connected, including how people feel, their social situation, all ties into their symptoms. So making sure you're kind of treating the whole patient, as we always do. And then prevent iatrogenic harm. As a hospitalist, I see this a lot. If patients don't get the answers they want, they just keep searching. And eventually they will find somebody out there, whether it's any kind of specialist they want, who will do procedures on them they might not need. So sometimes making sure to try to avoid procedures if they're not absolutely necessary does a lot for the patient. And the fourth one, or the last one on this list, is exercise. There's a pretty good study that came out that shows the benefits of exercise, which are also multi-system, just like COVID was. There's not a great theory as to why this works, except there's a lot of different reasons. Maybe it improves endothelial function, improves that exercise capacity, but it seems to be improve all the symptoms kind of equally across the board. And this can be a prescribed exercise regimen you can do with physical therapy. It can be just getting up and moving. It doesn't have to be very specific, but something is better than nothing. So that's mostly what I have on the post-acute COVID side of things and kind of where it's at. It's still evolving. Like I said, unfortunately, a lot of the treatment recommendations are just treat the symptoms. And with that, I'm going to go on to kind of this transitions of care. So if anybody uses Epic, you'll recognize the right side of this slide as kind of a template that goes into the EMR. And a lot of times you'll get a patient back to clinic and they've just got a template that has been filled out from the hospital. It's very busy. It can have tons of images. It can be a novel to try to get through, and you have no idea what happened in the hospital. And even after going through every page of that, you might still have no idea what happened in the hospital, unfortunately. So transition to care is something that I think COVID really exposed, because before you had family members who were in the room and they're like, oh, I was there, the doctor said to do A, B, C, and D, we're going to see our PCP, and they're going to do these follow-up tests. They're going to follow up the results from the tests we had in the hospital. And there was this communication that was maybe barriered by family, kind of carried over. The initial part of COVID, obviously, we didn't have that, and it made transitions very difficult. Our providers in our local community in North Mississippi would often give us a call at the hospital and say, look, I've got these patients and I have no idea what you've all done to them, but they're coming to me saying, I stopped these 5 medicines. I don't know which 5. I don't know why. What's going on? So we started kind of a transition care clinic with some of these providers, which was very nice. And they have access to our EMR, so they fortunately can kind of dig through some of the more detailed stuff that's maybe not in the discharge summary or the packet the patient would take to their PCP. And apparently Medicare now does have a billing code specifically for transitional care. So we have a couple providers, that's mostly what they do. They just see patients who've left the hospital in the last week and they try to transition them back into the community, almost like a liaison between the hospital and their PCP. And some private insurances, our main one is Blue Cross, they have started doing this as well. They actually have 2 different codes that they'll accept for transition of care back into the community. The other thing I see here, and might be a hot topic, I don't know, I don't get to see it very often, but the more open our notes are, so patients can now see their notes, which means that they can give them to PCP to see all the notes. Let's say they didn't get them. They can see all their records, all their lab values, all their images. So I think giving the patient that power to say, here is all of your material, all your data, all the tests we did, our interpretations while you were in the hospital's test, you can share it with your PCP. And hopefully they'll be willing to do that and take kind of that my chart or whatever your EMR calls it and share that with the PCP to kind of make that transition a little bit smoother. That would be kind of one of the goals for sure. In summary, so post-acute COVID-19 or PASC is a syndrome, refers to a range of symptoms. It's multi-organ, just like the COVID disease was, can last for weeks to months. The last I checked, that Nature review that I kind of got a lot of the information from was 2021. Since then, it seems like, for the most part, after 3 years that we know of, a lot of people with the post-acute syndromes have improved with, like I said, symptom management, exercise, getting their functional status back. The severity of your initial infection doesn't seem to matter on whether you get post-acute COVID. Like I said, that kind of excludes patients who had other syndromes like hospital complications or post-ICU syndrome, which are separate. And then the structured physical activities, multiple benefits, alleviates the symptoms of post-acute COVID-19. And with that, I think that is everything. And we're good.
We can open up for questions for Dr. Williams and Dr. Cottrell.
I'm curious, have you had any experience with stellate ganglion blocks or L-methylfolate for long COVID?
I have not. I had one patient who did have a stellate ganglion block, but it wasn't for post-COVID. I forget what it was for, but I have not. That's interesting.
Yeah, the data is kind of all over the place because they don't have a large N in there, and nobody knows exactly how it works. But yeah, I was just curious if you had experience with it.
Couple questions. I guess first for Dr. Cottrell, is there, I know you said that insurance companies are, I guess it's becoming more common that they're covering hearing aids and that kind of thing. You know, I think you see on like late night TV and that kind of thing, these amplifier, you know, type things. And I guess depends on what type of hearing loss they have for sure, whether or not that would work or not. But is there any, I mean, somebody that can't afford $3,000 hearing aids, is there any utility or any other modalities other than hearing aid that you can use?
Yes. So firstly, as of October of last year, there now are over-the-counter hearing aids. FDA announced that classification like years ago, but it went into effect last October. And there's probably 50 different companies who now have hearing aids available over the counter. Over the counter hearing aids are designed for mild to moderate hearing loss. So if a person has a milder, not a big problem, Amazon, there's 50 or 60, and there's more coming all the time. How effective is brand X that I found for a good deal? That would be hard for me to say. I don't know. And then if patients really are not in a position, I don't have $200, I don't have 20, then we're talking about communication strategies, especially with the family. Talk slower. Make sure. I always tell the spouse, get a running start. Instead of saying, hey, can you get that for me? Say, hey, Jim, can you hear me? Will you get that for me? And I had a patient come in and say, you saved our marriage. I mean, they're being a little silly about it, but simple communication strategies go a long way. In fact, especially for the elderly, the hospice community, and people who investing in hearing aids at this stage of life is not a good idea. The most important thing to do is speak slowly, speak clearly, get a running start, and then repeat and rephrase if needed. Those strategies are more important than hearing aids.
And then for Dr. Williams, I'm kind of interested in that patient that you and your pulmonologist treated on the CT scans.
Yes.
Do you remember the steroid regimen that y'all actually used?
Yes, so we did 3 days of Solumedrol, 500 twice a day, so a gram a day for 3 days. And then it was, while inpatient, 60 of Solumedrol TID. I think that went on for a total of, they were in the hospital 10 days. And then once we discharged outpatient, I believe it was 60 PO daily with a pretty long taper down like 10 milligrams every 2 weeks until they were off. Or until they followed up with pulmonology, I think was actually the right answer, which was still a while.
And did you use antibiotics as an adjunct, or so it was both?
Yeah, you know how it is. We didn't know what was in there. They didn't have a fever, they didn't have signs of infection, but if you don't know and they're pretty sick and hypoxic, then yeah, we used antibiotics initially. I think probably 5 days of just general broad spectrum vanxosin. And then when they were just getting better, and it seemed like the steroids was probably the number one thing. We were fortunate there. We did get a lung biopsy as well. Like first thing next morning, they did an endobronchial ultrasound with a biopsy. So we did eventually, a few days after we'd already started treatment, have some kind of answer from the biopsy.
Any other questions? Okay. Thank you, Dr. Williams and Dr. Cottrell.
So my name is Amy Drittler. I'm the Director of Alumni Services and Continuing Medical Education at LMU-DCOM. Thank you to all of you, both in person and online, for attending our conference this weekend. We've loved learning with you this weekend. Thank you for being here. As I go through our end of conference instructions, I'm going to ask the osteopathic physicians in the room to please raise your hand so that you can receive your attestation forms. For the online audience, if you will go to the downloads link at the top of the page that you're on, you will be able to download the appropriate attestation form for your profession. If you will fill that out and then submit to me via email, amy.drittler@lmunet.edu, we will process those. We also have both for our in-person attendees and our online attendees, we have a program evaluation. We will ask you to fill that out and submit to us as well. We do plan each year's conference directly based on the topics that are asked for from the previous year's attendees. We take your input very, very seriously, so please fill that out for us and let us know what you would like to see in next year's conference. I'll also say if there's any questions from the online audience about procedures, I think you could type that into the Q&A and relay those to us at this time. We're about done passing out our forms for our osteopathic physicians. The presentations this weekend have been recorded. Please give us a few days to get those processed and those videos uploaded online. But you can return to LMULive.com, click on downloads, and there will be video links to each of those presentations. So if you've missed something this weekend, you can watch that online and submit an attestation form for it later. Now all of our non-osteopathic physicians, so if you're an MD, a PA, or an FNP, please raise your hands high so you can get your forms. I will also note that please mark your calendars for the second weekend of June annually. We have this conference every weekend, the second weekend of June. Next year, our host hotel will be Wilderness at the Smokies, and our conference location will be the Sevierville Convention Center, which is attached to the Upper Lodge at Wilderness at the Smokies. So please make plans to be with us again next year. Okay, we have a Q&A that says the online evaluation is inactive. I will check that and see where the glitch is, and we will get that up and running and to you as soon as we can. So check back at LMULive.com. You can submit that. It does not have to be today. It can be in a few days. Are there any other questions from our online audience? Does everyone in the in-person audience have a form to fill out, an attestation form to fill out? Does anyone need a copy of the program evaluation that in the in-person audience? We have one up here. You can drop your forms at the table, the registration table out here as you leave. If you'd like to recycle your badge, please just lay it on the table too, and we'll take that for you. Thank you again for a wonderful conference, and we hope to see you again next year.